yes, yes. Of course. Yes. Yeah, fine, very fine. Because I have my presentation, and so yes, it's perfect. No, no, I don't hear. I don't hear. About 15 minutes. 15, what? No, no.
Testing one, two, three. Testing mic 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 one, two, three. Good morning. This is Sixth Gulf Conference on Burns and Wounds Management, Day 1. Testing mic one, two, three. Testing mic one, two, three. 1, 2, 3. 1, 2, 3. Testing mic one,
Is it
two,
on
three.
my computer? No. Okay.
After this one, we'll delete it. Is it okay for you?
Yes, but you have
Because it's not
PowerPoint.
detecting.
You
Yeah,
have.
we can. I'll bring. I just stay there.
Wait,
I'm speaking. Okay.
I don't have the.
Testing label 1, 2, 3. 1, 2, 3. Testing. Testing mic. 1, 2, 3. 1, 2, 3.
Yes, yes, okay, but yes.
This meeting is being recorded by the host or a participant. Can you put me whatever is happening? Can you? Sorry, you can copy.
Okay, okay.
Yeah, you can copy.
Now,
You don't
oh,
have the.
fuck. How? You want?
There's no USB in that side also.
No,
No.
no. We want to in my room. Yeah, 10 minutes. 10 minutes.
Sure. Testing mic 1, 2, 3. ഉണ്ട് ഉണ്ട് അടിയിൽ ഞാൻ കാണിച്ചിട്ടുണ്ട് ഇതല്ല പിന്നെ ഒരു മോളിലിട്ടുണ്ട് പുള്ളി എടുത്തോട്ട് പറ നാലാമത്തെ ഇൻപുട്ട് ഒന്ന് ഇത് ചെയ്യാൻ പറഞ്ഞ് സെൻഡ് ചെയ്യാൻ പറ നാലാണോ ഒരു മിനിറ്റ് No, I have to share my screen to the conference link. See, this is, I click that. Good morning. This is Sixth Gulf Conference on Burn and Wounds Management. Good morning. Testing mic. Testing mic 1, 2, 3.
شفت من جبه؟
You can see that.
ما نقدر نستغني عنها.
Testing mic 1, 2, 3, 1, 2, 3. Testing mic 1, 2, 3, 1, 2, 3, 1, 2, 3. Test one. Check, check.
Test. Check, check.
Good morning. Testing mic 1, 2, 3. Testing mic 1, 2, 3.
Check, check. Good morning, ladies and gentlemen. Welcome to the 6th Gulf Conference on Burns and Wounds Management 2022. Hope you all are doing good this morning and loving. How are you all doing this morning? Thank you so much for your response. The conference serves as a premier event on the international calendar to facilitate the development of burns and wounds management, providing opportunities for physicians, nurses, healthcare executives, physiotherapists, dietitians, researchers, and clinical professionals to share clinical experiences, the latest cutting edge research results, and technological innovations for clinical management. In our excellent in lieu of faculty, you will have an opportunity to interact among surgeons from different parts of the world and promote productive information and exchange and stimulate interesting and pertinent discussions. Isn't that great, ladies and gentlemen? At this stage, I would like to welcome our conference president, Dr. Marwan Al Zarouni, to say a few words. Let's have a huge round of applause for Mr. Marwan.
Thank you.
Thank you, sir.
Assalamu alaikum. Good morning, everybody. In true Arabian spirit, we would like to extend a special warm welcome to the speakers, delegates, and attendees, particularly those of you who are traveling far to be with us during our National Congress with global experts in the field of wound management and burn care. We are delighted to host you all for the coming days in Dubai, United Arab Emirates. We continue to strive towards a multidisciplinary environment that ensure academic excellences. This year, we have joined forces with our international and regional colleagues, as well as plastic surgeon societies from Saudi Arabia, Bahrain, and Oman. This gives us all the opportunity to provide tremendous strength to the Congress and to the region. Our goal today is to continue to build on these important relationships and partnerships that will strengthen the future vision and mission of the wound and burn care in the region. The world of burn and wound care is an exciting area to venture into in terms of work, study, and play. and we will continue to meet and bring inspired plastic surgeons with their teams of doctors, nurses, and therapists together in congresses like this to ensure our specialty gets updated, cutting-edge technology, and information on key issues. It will also be a great opportunity for major companies to present their new products and interact with the teams. We sincerely hope that this meeting will be a worthwhile opportunity for everyone, which can create greater interaction between different parts of the world and to promote productive information exchange and stimulate intriguing discussion among us. Finally, we hope that all of the delegates will have a memorable experience and a wonderful time in Dubai, United Arab Emirates. Thank you.
Thank you so much, Dr. Marwan. May I please request now Mr. Claudio Ligresti, Consultant of General Surgery Plastic at ICLS Rapallo. Can we have a huge round of applause for Mr. Claudio?
No, one is. Yes. But where is the? Okay. Dear gentlemen, ladies, everybody, good morning. Before the starting my speech, I like to thank conference organizers, Dr. Marwan, Dr. Savat, for kind invitation at this important Congress. And for me, it's very honored for the second time to coordinate the Italian Academy delegation with some professors that I will present. The problem of wound care is always doesn't not heal because the wounds are not simple to treat. Why? Because the therapist changes. Explosion of basic science results in the field of wound care over the past 20 years. Initially, wound dressings were the only therapeutic options. But we have now an arsenal of dressings, biologic tissue, genetic therapy, physical therapies, plastic surgery, and other treatment options. What has not, however, kept pace with these changes is the education and practical training for those treating not healing wounds. This happened in Europe, in Italy particularly, and as wound healing is not considered a medical specialty, there is no formal training process for physicians and nurses. For this reason, since 2011 was born IAWC, is a high school, theoretical practical management, learning test and clinical practice, interaction, wound technology, workshop, clinical centers internship for doctors, nurses, pharmacists, pediatrics.
In the US, 67 million people develop skin wounds and ulcers in 1 year, and an estimated 39 billion is spent on their treatment. Unfortunately, the number of specialists able to diagnose and treat them is very low compared to the demand. Poor prevention and insufficient training. In 2011, IAWC, Italian Academy in Wound Care, was founded by Professor Claudio Ligresti.
Per il 2022 il corso è diventato biennale e si esce con la qualifica di expert. I nostri studenti hanno addirittura a volte cambiato persino lavoro, sono diventati autonomi grazie a questa formazione.
A high-level training course dedicated to doctors and nurses for the management of diagnosis and treatment of skin wounds, capable of training experienced healthcare personnel in only 2 years. With internationally renowned professors and collaborations with over 10 Italian and foreign universities, IAWC has seen more than 300 experts graduating and working now for public and private health facilities in Italy and abroad.
Grazie al professor Claudio Ligresti abbiamo realizzato la convenzione tra l'Italian Academy of Wound Care e la scuola di specializzazione di chirurgia plastica, ricostruttiva ed estetica dell'Università degli Studi di Roma Tor Vergata. Questo modello applicativo porterà vantaggi nel campo della didattica pratica, di neospecialisti, nel campo della ricerca scientifica, nel campo dell'approfondimento, ma non solo per la chirurgia plastica, un po' per tutte le branche che ruotano attorno al variegato mondo della vulnologia e del wound care.
10 anni ormai che collaboriamo con il professore nella crescita multidisciplinare, quindi tutte le figure di interazione non solo a livello regionale ma a livello nazionale.
Besides theoretical classes, the Academy offers practical drills and simulations of clinical cases. Italian Academy of Wound Care takes part in international congresses and organizes humanitarian missions to grow knowledge about the treatment of difficult wounds. ASTI is one of the excellences in Italy and abroad in the training of doctors and nurses specialized in wound care. IAWC is based at Uni Asti's campus, home to scientific research and advanced training. The Academy includes internships in clinical centers of excellence for the treatment of difficult wounds at public and private hospitals through practice activities in the clinic, ward, and operating room.
La frequenza in centri come il mio per vedere tecnologie e chirurgia plastica applicate nei casi più difficili di guarigione di ferite complesse, o le frequenze in altri centri per il piede diabetico o di wound care in generale, permetteranno di acquisire un'esperienza diretta ai discenti che di solito è ricordata come una delle cose più importanti di tutto il corso, con un feedback molto positivo.
Lo specialista in chirurgia plastica non avrà solo il compito di passare alla fase operativa chirurgica, ma potrà essere l'elemento coordinatore del team multidisciplinare che sarà poi portato alla cura di quella ferita difficile.
È importante all'interno di questa accademia la presenza mista di medici e infermieri tra i discenti, ma anche tra il corpo docente, perché questo consente di avere sempre una interazione ed una multidisciplinarità anche tra di noi.
Noi insegniamo e diamo le nostre conoscenze ai nostri discenti, ma allo stesso tempo siamo noi che apprendiamo dal nostro team di docenti che siamo multidisciplinari.
Italian Academy of Wound Care produces job opportunities thanks to the skills acquired in wound care.
Ho potuto conoscere molti colleghi, medici e infermieri da tutta Italia, quindi io penso che IAWC mi abbia anche regalato una sorta di grande famiglia professionale. Sono stato in sala operatoria a toccare con mano, proprio il caso di dire, medicazioni avanzate, medicazioni dove si va oltre.
IAWC ti dà gli strumenti per affrontare la cura in un'ottica diversa. Prendersi cura delle persone con lesioni difficili implica la conoscenza di tutto quello che è uno sviluppo nuovo delle tecnologie. Si scopre molto l'importanza della multidisciplinarietà tra gli operatori.
AIWC assures us a bright future.
Just this is a movie for my is very, very important to show you this movie because it's done from 2 months, and our teacher organization includes the recruitment of teachers from national, international university and hospital, And the selection of students is very, very important about their regional interview and the curricula. And the course lasts 2 years with external internship and sometimes announcement of the best students with tutoring assignments. I like to introduce you some speakers from the Italian delegation of IAWC, Professor Valerio Cervelli, Director of Plastic Surgery at Tor Vergata University of Rome, Professor Franco Bassetto, Director of Plastic Surgery University of Padua, and Giacomo Clerici, Chief of Diabetic Foot Center, San Carlo Hospital, Milan. He isn't now, but he logged in with you with the online system. Delegation of IAWC speakers will speak about the skin lesion in COVID patients and then the clinical cases of skin necrosis. The partners of IAWC are a lot. Of course, for universities, hospitals, and wound care centers, states, governments, international health cooperation, also for humanitarian mission. And so we created a new group, international group in 2020 to study and to treat the skin lesion in COVID patients. The IAWC participate in many congresses and masterclass, in particular Switzerland and Latin America area, but also for second time in Dubai, and include the research with the multicentric research work about assessment, physical therapies, wound dressings, and regenerative medicine. Our program is multidisciplinary, and the regenerative medicine is very, very important. The treatment provide, of course, the first time the assessment, and the second, the study of the better protocol. Sometimes use the time-match protocol with therapeutic synergism with the necrotic tissue takeoff with the special debridement, and use of physical therapies like biophotonic therapy, VAC therapy. We'll speak about that, Professor Bassetto. A temporary protection with epidermal substitute and dermal substitute to arrive sometimes with spontaneous healing or with the plastic surgery with skin graft and flap. And so the use of regenerative medicine included the use of blood components for topical use, fat transplants, and the dermal matrices. Why? Because for us it's very important to get a good receiving tissue with these physical therapies, and you have, after the skin graft, after flaps, or before, avoid the fibrosis of the scar. For us, it's important the elasticity, the softness, the good color is not very important to plug the hole, but to have the good scar. And for the reason, the next November, I will organize the next master class about the complex wounds and ulcers in severe traumatic events with the frontal circular lessons and techniques for the reconstruction of complex wounds on a cadaver. Will held in Asti University and also in cadaver lab with the dissection and demolition and reconstruction of lower limb and foot. And why not combine science and tourism to visit famous and historical cities in Italy, like Rome, Venice, and Turin, and to have the pleasant company with a traditional Italian dinner, tasting truffles, drink quality wines, and particularly cellars like Marchesi di Barolo and other sites. And thank you for your attention.
Thank you so much, Mr. Claudio. We are truly delighted by your humble presence. May I now please invite on stage Mr. Ignacio Garrido Stojas in our midst, a doctor of medicine and specialist in aesthetic, plastic, and reconstructive surgery in Paris.
Thank you. So, we can start. Okay. So, Mr. President, dear colleague, this is my pleasure to be here in Dubai for our amazing conference. And I would to thank you for your kind invitation, and especially my friend, Professor Al-Katani. I don't know if he's here this morning. And the topic of my communication is surgical wound in oncoplastic case. Probably is because I have a long experience doing plastic surgery in the field of cancer, 15 years in a cancer center in Toulouse for breast, head, and neck reconstruction, but also for skin cancer. Now I'm practicing. Oh, what's happened? Sorry. Where is the presentation? Ah, okay, this one. Now I'm practicing in Paris. I don't move. I don't know what's happened. Okay, let's start again. It's okay? So, with your permission, I will today to make a reorientation of my communication and access my proposal more generally on wounds in oncology. I think it's the most challenging field for plastic surgeon. And you know that oncological wounds have a special that make them challenging. When tumor from getting out and causing risk of bleeding on that smell, our role as reconstructed plastic surgeon is to elevate it and treat according to the case we are dealing with. First, you know that these wounds never heal spontaneously. They grow in surface and deeper. They become quickly painful. They exudate a lot. They get neovascularization, who will make them hemorrhagic, and after weeks they become to smell bad because they become infected. And they make have frequent association of anarchic proliferation and ulceration. The particularity of wound in oncology needs a global approach, including three components: cancer first, of course, in particular in terms of prognostic, but also the patient with his more comorbidity and all the factors that can perturb the cicatrization. And the treatment also in terms of morbidity and in the chronology of the treatment. It's a chain of treatment. As a surgeon, the first question that I ask myself is the wound due to the cancer? If it's yes, could the surgery treat the cancer in one step without adjuvant therapy, adjuvant treatment? If not, I have to ask myself if there is possibility of treatment of the wound with other treatment in association or not. And I will show you, to be clear, two same case of patients who had squamous cell carcinoma. the one on the left of the nose and the one in the right of the left eye. The first one have the lucky to have only local extension, and the exam was negative for distant disease. So we treat the patient only with surgery, and we make an easy reconstruction with prosthetic nose, because this patient was active smoker, and he take more than 20 cigarettes by day, and it was a very difficult patient to manage. The other patient was metastatic with infiltration in the brain, and in this case, the treatment of the wound will depend on the treatment of the metastatic cancer, in this case with immunotherapy, with a low chance to have reduction of the wounds and the cancer. So in this case, we will try to give some comfort to the patient. What we know it's palliative take of care. And we know that in this case, the dressing will be a support of healing. That means we have to work with the team of nurse, and as a physician, as a doctor, we have to know all the dressing, because there are a lot now, the type of dressing, and not only the category of dressing, but also the form of dressings. But we have to treat the wound, the oncologic wound, and we have to take the specificity of the wound, and one of the most important is the pain for the patient. So we have local decision we can take. The first one is choosing a dressing with an atraumatic undressing, make humidification of the dressing before the undressing, and use local anesthetic, like Xylocaine or Emla. We can take a general decision, and we discuss pre-medication before the dressing. We use Antonox and adapt anti-analgesic treatment. If need, we use a referent doctor for anti-analgesic treatment. For exudation, we choose a primary dressing with a big absorptive power and use a second dressing with a great absorption power, bigger than the primary dressing. If the dressing change happens too often, we use negative pressure therapy. For bleeding, when undressing the wound, we choose a primary dressing less traumatic when undressing and with hemostatic properties, like alginate. And we choose to moisten the dressing before undressing. If the bleeding persists, we make a compression and we use a hemostatic dressing. If the bleeding is uncontrollable, so we transfer the patient to the hospital, and except in the exceptional case of we decide before that the patient could die at home with bleeding. In some cases, we use irradiation for hemostatic effect to control the bleeding. For smell is linked to bacterial proliferation, especially anaerobic bacteria. So we take local measure, like mechanic detection has to be the first decision to take. Then we can discuss agentic dressing. We can also discuss local antibiotics like metronidazole. To reduce the smell, we can offer an absorbing dressing, Caracol dressing. And we take general measure if necessary with antibiotic. For infection, you know, every wound is colonized by bacteria, usually saprophic bacteria like Staphylococcus. And the question is, have we or not to make systematically a bacteriologic sample? we only use that when we have sign of infection, because we know that we will have some bacteria in the wound, and we will make nothing with the results if there is not sign of infection. I want to talk a little bit about the negative pressure therapy, the vacuum-assisted closure therapy. You know, in the clinical guidelines, they said there is a contraindication to use the vac therapy when there is malignancy in the wound. But for us, in our practice, when we have a patient in palliative state, because the patient will die in a few weeks or few months, we decide to use the vac therapy only for the comfort of the patient. Like in this case, it's a young man that have a relapse of inguinal nodes after squamous cancer of the penis, and he had a very painful wound with exudation and bleeding. We used the vac therapy, and we informed him that he could have an hemorrhagic wound, and he could die with the vac therapy. That occurred 1 month after, but it was very happy because he could see the family and the friend for 1 month, because before he was blocked at home. And we published this technique in the palliative medicine in 2014 with 3 cases, the same case on the left at the top about melanoma on the posterior face of the leg. Patient who could not go out because of the wound exudation and pain. So we make excision, vac therapy, and after 1 month she died. The same on the top on the right about the recurrence of breast cancer and the sarcoma of the leg above. I want also talk about the complication of the treatment in the field of oncology, because we have sometimes some wound not due to the cancer, but due to the treatment. Here, for example, it was a patient who was treated for sarcoma of the thigh, and she had, after the surgery, vac therapy and skin graft, and after, for the treatment of the sarcoma, radiotherapy. So 3 months after, she was like that, and the colleague sent us the patient and asked a solution for her. So we decide to make excision of the wound, large excision, and after make a reconstruction with a contralateral, anterolateral thick flap, free flap. And I think this patient could have, before this surgery, to treat the sarcoma, but we have also needs to talk with our colleague, because it was operated by the orthopedist, to learn them that the plastic surgery could make the reconstruction at the first time and not after the treatment, because it's more difficult for us and more difficult for the follow of the surgery to have the radiotherapy before. Another case, I'm sorry for the picture, but it was not my patient at the beginning. This patient have a chemotherapy for left breast cancer. And after the first time of chemotherapy, she had a chemonecrosis of the right breast. So she had, after a mastectomy of the health breast. And we have to make the reconstruction. At the beginning, we want to do the reconstruction with diaphragm flap, but she had, as you can see, just 2 weeks before the surgery, a cholecystectomy. So we decided to make a latissimus dorsi breast reconstruction with two times of lipofilling, and after we could have a reconstruction. But it's a very difficult case and very complicated because there are a complication of the chemotherapy. So to finish in conclusion, I want to say that we could take all the day to speak about this field of wound management because it's very interesting, it's very difficult, and I think it's a very challenging field for plastic surgeon and oncologist to treat the wounds in terms of plastic surgery, not only, but also in dressing field. I want to thank you for your attention.
Thank you so much for joining us, Mr. Ignacio. The information that he shared with us was indeed very useful and helpful. Thank you so much for sharing this wonderful information, sir. We now move to our first panel session, International Experience in Wound Management. May I please welcome the moderator for the panel, Mr. Claudio Ligresti, to address the gathering.
Okay. Thank you, my colleagues. And it's very important the next section about the management of difficult wounds. And I like to introduce some speakers from Italian delegation, from Italian Academy Wound Care delegation. Professor Franco Bassetto, he is the director of plastic surgery, University of Padua. Professor Valerio Cervelli is the director of the school and the Department of Plastic Surgery of Tor Vergata University of Rome. And Dr. Giacomo Clerici is chief of diabetic foot in San Carlo Hospital in Italy. And mine. This section is important about the explaining of the use of physical therapies, of the use of treatment, in particular inflammatory disease, and for the ability of the treatment for the problems about the diabetic foot. And so I like to begin with my speech about the causes of difficult wounds in international created wound care group that was organized in 2020 year. Well, the first slide to remind the COVID spread around the world and the hits after Europe, especially America. But what's happened really? The storm, the inflammatory storm with the problems about malnutrition, vasculitis, thrombosis, and the production of precious ulcers, inflammatory ulcers, and skin ulcers of iatrogenic causes. And for this reason, in the lockdown time between April and June 2020, I organized with a lot of friends, a lot of experts from every country in 4 continents, a particularly special international wound care group to study and to treat the skin wounds in COVID patients. We organized 4 international webinars, also the national Rai News 3 is in national TV, interested to that webinars. The moderator for 4 webinars was the Professor Valerio Cervelli. And we treated the 4 big problems to solve. Why do skin ulcers form? How to treat them, how to prevent them, and how to organize the treatment of others' disease during the lockdown. Well, for me, it was a very honor to organize that group with angiologists, dermatologists, plastic surgeons, vascular surgeons, a lot of specialty cooperations. And finally, we have written particularly one of the first scientific articles about the practical management of the skin lesion during COVID-19 in Wound Journal Surgery and Surgical Research. But what's happened really? It happened the presence of particularly angiotensin converting enzyme 2, which is the primary receptor for SARS-CoV-2 entering skin cells, might explain some of the vascular skin lesion on COVID-19 infection due to significant immune antiviral response. Virus-induced skin eruptions and either direct or indirect effects on the infection or the result of drug hypersensitivity, while no virus-related skin damage. It was very important, the lesson by Professor Novelli, he's a genetist in Tor Vergata University, is explained the particularly interesting about the genetic problems. Individual difference in genetic makeup may explain our susceptibility to new coronavirus and the severity of the disease it causes. While for hormonal difference, X-linked genes, HEL genes, blood group difference, and other problems. Problems by drugs with the production of thrombosis, about the antivirals, antibiotics, anticoagulants, biologic drugs, and immunosuppressive and immunomodulatory agents are applied separately and simultaneously, leading to drug-induced skin eruptions and the production of ischemia, and by the use of noradrenaline, dopamine, are drugs very important in intensive care. Another problem was explained for the malnutrition. We know the problems for the obesity patient, and SARS-CoV-2 can attach the mucosal epithelium and cause gastrointestinal symptoms. More of 27 patients over 65 years old were at risk of malnutrition, with weight loss very, very important. How to treat them? Professor Motolese from the Dermatology University of Reggio Emilia explained the vasculitic factors. Most of skin lesions about urticaria, eruptions, hate the children and the young patients. Most of the skin lesions, fortunately, disappeared spontaneously. But one of the most important problems was and is the ventral 24 to sure ventral ventilation, the ulcer pressures in sternal positions. This problem produced also the facial edema. How to prevent them? With the change of and the prevention of pressure ulcer, change the position of the patients and control of redistributing of pressure and the equipment in bed and chairs, and continence and nutrition care. Skincare such as cleaning and protection, microclimate control, the emerging evidence for prophylactic dressings. How to treat? With a lot of advanced dressing like hydrocolloids, collagen, polyurethane, silver, against the infection, antibacterial dressing, and dressing with the bioactive materials in case of adequate bed vascularizations. But the most important challenge was about the surgery, because some operating room was closed, and the plastic surgery used in the optimal therapeutic protocol, in sometimes for sternal ulcers, and use, for example, about the negative pressure that spoke the previous speakers. And well, in this case, negative pressure is very attention to use negative pressure, because it can produce the worst results if it is used with the high pressures. And it's very important that the use of biophotonic therapy designed to stimulate healing through disinfection and the stimulation of the tissue regeneration. And so attention and mobility for surgical patients with the clinical practice guidelines indicate the use of special beds for patients with alteration in their state of consciousness should mobilized frequently every 2 hours, especially after reconstructive surgery. And finally, the prevention for healthcare workers to prevent the facial injuries from prolonged contact with the mask with extra thin hydrocolloids and protective creams. And why not to don't speak about the general prevention measures and rules in the hospital that rules that produced the reduction and produce now the reduction of non-urgent patient care activities. Don't close the hospital to no COVID patients is the very problem. In the lockdown period, a significant increase was found in the overall out-of-hospital mortality, 43%, and the cause specific out-of-hospital mortality related to neoplasma, endocrine and nutritional and metabolic and cardiovascular disease. How to resolve this problem? Well, with the home care pathway, sometimes with the nurses in the home of the patients. But it was, and this is very important, for example, the telemedicine, with the contact, the doctor, the nurses with the patient in their home, sometimes can resolve the problems. In conclusion, some consideration. Educational programs are needed to train staff on COVID-19 related skin conditions. Severe skin inflammation from endogenous inflammatory substance and the drugs, they don't produce the same effects on all infected patients, but depend sometimes by the genetic problems. Hyperperfusion and failure to release of O2 in peripheral tissues with deducible consequence of possible new skin lesions. These lesions appeared mainly in young patients and often disappeared without leaving any consequence, fortunately. The pronation position required for patients with pneumonia has hindered an efficient and preventing strategy due to limited resource, high-risk surface, malnutrition before admission, drugs are problems, of course, but telemedicine and a skin pathway can have help for us and for the patient. Some hospitals should remain COVID-free and allow other patients to be treated without problems, avoid worsening of disease for which close monitoring is necessary. And we hope well, of course, and thank you for attention. Well, after my presentation, this is the introduction. I like to introduce you the new speakers, Professor Franco Bassetto. He will speak about the precious ulcers, and Franco is the Director of Plastic Surgery of Padua University. Franco.
Thank you very much, Excellency organizers, dear colleagues, ladies and gentlemen. It's a pleasure for me to be here for the third time to share with you our special experience in the last period related to the pandemic that really changed the world of wound healing, not only in Italy, but all over the world. The topic that I would share with you, it's the pressure ulcers topic that is related to, I don't see on my laptop, that it's related to the fact that we know that pressure ulcers are really the focus in which all plastic surgery can give the best for resolve problems. And during the pandemic, as you have seen, new problems with pressure ulcers became our problems in this management of patients. Trying to go back to the origin of pressure ulcers, we know that if pressure or a compressive strength is maintained for a sufficient time period, a pressure upper than 32 millimeters can cause lesion if a patient is maintained on a traditional operative bed for more than 2 hours. And we know that during the pandemic, unfortunately, these patients stay on not only on the back, but even on the thorax region for longer time, because it was really a period of emergency and we don't have enough nurses dedicated to these patients. So for this reason, we know that if pressure at bone level, sacred and trochanter, that was the traditional pressure ulcer, can reach a very dangerous pressure, we can have both things, ischemia and the lymphovenous stasis. And we know that plastic surgery nowadays is particularly seeing the role that the lymphovenous stasis has in wound healing, and we are particular in trying to understand better what is the lymphovenous stasis. And exactly 1 week ago, I was here in Dubai with the VU Winter Group, that it's a world group that is studying the effect of lymphovenous network in healing, in wound healing, and in plastic surgery. So we had an increasing number of patients with tissue damage. But if we see the traditional EPWAP classification about pressure ulcers, we know that we have 4 stages. And fortunately, in COVID patients, we have first and second degree of these ulcers that was
not so hard to treat, because we know that with a good dressing and good prevention and a good locally system of treatment, we can obtain and heal. So the surgical phases. What is the role of plastic surgery on pressure ulcers? Surely accurate debridement of necrotic tissues, and then I will speak about technologies that is a new power that plastic surgery has, that combining with surgery is giving to us a lot of improving in the last years. Radical fistulectomy, radical debridement, and possible osteotomy if there is a documented bone involvement. We know that the bone involvement is related to the fact that the pressure ulcer has a long time. So in this pandemic, fortunately, these patients were acute pressure ulcers. So most of them has no problems of bone. Anyway, we introduce, especially during the pandemic, the possibility to put negative pressure therapy. In our experience with installation, we are using installation nowadays most of the times, because it's a very, very new possibility to reduce the treatment, and then the possibility to perform reconstruction with muscle flaps, perforating flaps, new generation flaps, or myocutaneous flaps. So what has changed during the pandemic? The fact that unfortunately we don't have the possibility to treat most of these patients immediately with the second or third degree pressure ulcer. And for this reason, negative pressure could be a good thing to treat and to delay the reconstruction when my department, for example, has the possibility to treat only traumatic patient or oncological patients, because what happened in Europe was that most of our surgical department was not allowed to treat all patients that need plastic surgery, related to the fact that nurses and residents, for example, were used for vaccinations, were used for COVID departments, and so it really was a revolution. So we are here in Dubai after 2 years in which we were like in a shock, because it was really 2 years of different treatment in which we had to reflect more about the role of plastic surgery and what will the future. Which flap? Traditionally, you know that you can use myocutaneous flap or fasciocutaneous flap. Surely most of them has advantage and disadvantage. Anyway, surely the advantage of myocutaneous flaps in pressure ulcer is the fact that it has excellent emetic support, a good thickness, especially for deep injuries, best efficacy in infections. And like Dr. Ligresti shows, in these patients in which we had an inflammatory condition, we had to prefer this kind of myocutaneous flap instead of fasciocutaneous flap, especially of last generation. So if we look to the experience of plastic surgery department in 8 years before the pandemic, you see that our patients were most paraplegics, tetraplegic patients with the traditional sacral, ischiatic, or trochanteric pressure ulcers. But during the pandemic, we saw new kind of patient with thoracic pressure ulcer or heel ulcers that fortunately was not so deep like the traditional one. The problem of infections. We know that in pressure ulcers, infection is a huge problem. Why? Because as we can see here, we can have a lot of different infections like Pseudomonas 1, Proteus, Acinetobacter, and Escherichia coli. And in Italy, but all over the world, the multi-drug resistant infection is a new problem in which sometimes we don't have enough drugs in our hands. And I will speak in the second my presentation about technologies, what we are using, trying to resolve this problem of multi-drug resistance. Anyway, we know that in patients with positive swab, and in 22% of patients with MDR, that it's a dramatic number in our experience, we can arrive to the osteomyelitis, that is a dangerous condition of chronic condition that we can detect through the so-called PET-TAC. And if the traditional area were ischiatic and sacral, during pandemia, we have hip decubitus that was very low because we didn't see so much patients that required plastic surgery for pressure ulcers during pandemia. Which was our reconstruction options. You can see that between 2010 and 2015, we prefer perforator flaps because they were new flaps in which especially residents were enthusiastic to try, knowing the angiology of the anatomia of these new flaps. But nowadays we are using again a lot of myocutaneous flaps related to the infection, the inflammation condition, especially in the last period. So we must go back to the anatomy to understand that if we know very well anatomy, we can perform different flaps that resolve definitively the pressure ulcer problem. This is the key rule of plastic surgery around this kind of ulcers, the pressure ulcers. And sure, now it's possible to do the cadaver lab, and it's possible to teach to young generation exactly which is the vascularity of the gluteal region, trying to understand for the most frequent lesions that are the sacral one, which is the best flap that they can use in a different condition. And for this reason, in the opinion of our plastic surgery group, in which a lot of colleagues from Egyptian were welcome in the past. We have a very good relationship with Egyptian society that sent a lot of doctors to perform in the cadaver lab, the possibility to know very well which is the difference from one flap to another one to use in such difficult area, to measure exactly where the perforators are, and then trying to resolve the problem, not only in the so-called random flap as we had in the past, but in a well-known anatomical flap that we have nowadays based on the superficial gluteal artery, that it's the key from the anatomic point of view to solve huge problems like these, and to maintain the no recurrent status that is very important, especially in pelagic patients. So, which is the, here you see that trying to understand better, especially using technology, now we can scan our patients and we can perform a 3D reconstruction. So technology are welcome, and you know that a young generation are particularly enthusiastic about this because we can study the patient before and after our reconstruction to understand better the anatomy that here, for example, is related to the different perforating vessels that could come from superior and inferior gluteal artery, like we published in this paper. So trying to understand better what we can do doing and knowing technologies, we can arrive to rise such flaps that are really resolving the problem in a definitive way, but permit to use the main a vascular paddle like the gluteal one in case of a recurrence. And this is very important because we know that especially pelagic patients, unfortunately, during their life, maybe will have a recurrence of their pressure ulcers. The perforator sparing buttock rotation flap is more traditional, it's more easy, it's our first choice if we want to avoid to use the gluteal vascular artery. And we have to put together anatomy and choices, and this is the key point of the rule of plastic surgery, that have fantasy, that has knowing of anatomy, and then can propose different solution, trying to combining different flaps to arrive to a stable healing for a long life quality in such patients that can, for example, come back to their sport activity. Here it's some clinical cases that we solve with these performing these different kinds of surgery for ischiotic ulcers, especially in young people. And these cases were not related to the pandemic. We don't have so huge cases during the pandemic period. The huge fistulectomy and the use of the right perforator to arrive to put together different flaps to solve and to give a stable healing for these patients that is an Olympic champion. Rotation fasciocutaneous flap with hemigluteus muscle flap, other solution after huge fistulectomy and rotation, stable healing. Other rotation flap in which hemigluteus flap and the traditional VY flap at left side was used, knowing that this is very young patients with 2 ulcers that you can see here. So we can put at the same time 2 different solution that only plastic surgery can give. So I think that this is really our fundamental rule. Or the biceps femoris myocutaneous flap, that is a second choice in such patients. Even in such case, the biceps myocutaneous and the fasciocutaneous flap. So in conclusion, you can see here different cases treated, even, for example, the trochanteric flap, that it's another option that we can use for the trochanteric area, in which especially this flap can be useful, like here, or in dramatic condition in which we can have ischiotic, sacral, patients that arrive from a huge history of the decubitus in which many different solutions were used with negative pressure, as you can see in the second case. Case related to new kind of ulcers during the pandemic are this one. You see the vertebral area that was the decubitus area in a patient treated during the pandemic, or other location like the malleolar area in which we have bone in a superficial area. Complication. We know that this patient could have complication related to hematoma, seroma, because they have not vascular control and relapse. We have to avoid as much as possible the relapse in these patients. Unfortunately, in our experience, we have 26.5% that it's in line with literature that has a rate of recurrence between 19 and 77. So the approach to these patients could be very trying to avoid recurrence, that it's here the problem. So in conclusion, we need a multidisciplinary treatment in such patients, considering that special patients during pandemic age are inflammatory patients. In this multidisciplinary treatment, the interaction with the spinal unit it's important, but the personalized reconstructive choice by the plastic surgery unit is fundamental. Then we can have a delicate peri-postoperative management with a rigid follow-up that avoid no correct position of these patients and a very well patient-family education collaboration. So I think that in such difficult patients, we have to use all we have in our hands, because the rule of plastic surgery in pressure ulcer is fundamental. And this is my group with a surgeon in the center that is coming from Jordan. So we hope to continue our relationship with people that arrive from the Middle East. You are welcome to Padova, and you are welcome to Academy of Wound Care if you want to work with us for improving your skill in wound care. Thank you very much.
Well, thank you, Professor Bassetto. And now, like is previous in the program, is possible the connection with Dr. Giacomo Clerici. Is in Italy, unfortunately, is with the problems. And
can you hear me, Claudio?
Okay, I'm ready. Oh, hi. Thank you for your presence. Giacomo Clerici is the chief of diabetic foot in San Carlo Hospital, and is a very expert in diabetologist, in surgical diabetologist also, and international expert in diabetic foot. And so, Giacomo, how are you?
I am okay, hopefully. So, first of all, let me thank the scientific committee for this kind invitation. I would like to thank all of you. Good morning, ladies and gentlemen, colleagues, chairperson. And first of all, I would like to thank also the IAWC for leading this very amazing session. So I try to share my screen, but the organizer asked to allow me to share the screen. Not possible. I am asking the organizer to allow me to do it, please.
Can share the slides of Giacomo Clerici, please?
Let me check again. No, the organizers doesn't allow to. Okay, try again.
Okay, start. Can you start?
No, not possible, because I cannot share my screen because the organizer doesn't allow me to do it.
Okay, there is important the connection into the
organizers must
the organizers
allow me
is the
to
Giacomo
share my-
Clerici.
Okay, no, organizers impossible to share.
The first pictures.
No, I need to, please, I need to share my screen, please. You have to allow me to share my screen.
Okay, some problems, Giacomo. Is better to pass for the other speakers, and
No problem.
in this time
I solved the problem with, yeah.
I called another speaker to prepare your speech. Okay, can you
Perfect,
wait?
perfect. I try to,
Can you wait
okay,
some
problem.
moments? Okay. Okay, I proceed with another speaker. No, now. Okay, Giacomo, can you share it with your laptop, your
No,
screen?
it's not possible because the organizer doesn't allow me to share the screen. They have to allow me to share the screen. I send them a picture of the problem.
Okay, just already the.
Okay, now I can. Perfect. Thank you.
Okay, perfect.
Okay.
Start.
Thank you, and sorry for this problem. So again, I apologize because I couldn't join you today and tomorrow, but unfortunately, the day before my departure, I have been found positive to the COVID test, and so I have been denied to fly to Dubai. So next time, I hope to be there with you. So the topic talk about patients at higher risk of major amputation, patients that we have treated in the pandemic period because we tried to keep safer at home, patients with simple lesions at lower risk of amputation and a lower risk of mortality. So I think that we must agree when we talk about diabetic foot as a syndrome. Diabetic foot syndrome leads to a high risk of amputation and mortality. And then this is the reason why we have to work together. We have to manage this kind of patients in a multidisciplinary setting with a multidisciplinary approach. This is the reason why we should have at least 4 teams. The medical team, because you know that these patients have a lot of comorbidities, the foot surgical team, the vascular team, and of course, the rehabilitation and prevention team. But the main problem, the main topic when we talk about diabetic foot is not the amputation risk, but is the survival. If you look at here, we know that the risk of death at 5 years for a patient with a diabetic foot ulcer is 2.5 times as high as the risk for a patient with diabetes, but without an ulceration, without a foot ulceration. And if you look at here, you know that if we compare the most frequent cancers and the mortality rate, you can see that patients with diabetic foot usually have a higher mortality rate when compared to patients with the most frequent cancers. In our experience, in particular in patients with ischemic diabetic foot, the mortality rate at 5 years is around 50%. And the leading causes are cardiac disease, sudden death, and stroke. So who is the patient at higher risk of major amputation and higher life risk? So these are patients that we have treated mainly in the pandemic era. Our patients with infection, our patients with ischemia, and our patients with infection and ischemia. But I would like to add another group of patients that, in my opinion, are always at higher risk of major amputations, patients with the shark foot in particular, and stage shark foot. Well, when we talk about infection, when we talk about diabetic foot infection, we usually divide these patients in 3 classes: patients with mild infection, patients with moderate infection, and patients with severe infection. Patients with mild infection can be treated in an outpatient setting. You can treat them with offloading, antibiotics, and dressings. But when we talk about patients with moderate infection and moreover with severe infection, we in an outpatient setting. We have to think always about an hospital admission. So these patients must be treated immediately into the operating theater. We have to keep in mind the surgical classification system by Professor Armstrong and Freiberg, and we talk about emergent surgery class 4. When we talk about ischemic patients, we talk about patients with peripheral arterial disease, the other complications of diabetes. You know that the etiopathogenetic causes are neuropathy and ischemia. Ischemia, it means that you have a peripheral arterial disease, but with different clinical features. We have patients without any symptom, we have patients with claudication, mild claudication, severe claudication, and we have patients with rest pain or ulcer or gangrene. So when we talk about ischemic diabetic foot, we talk about the patients with chronic limb-threatening ischemia. They are not patients just with peripheral arterial disease. They are patients with rest pain or tissue loss. And these patients must be treated aggressively because in many cases, just in a few weeks, just in a few months, you could have a major amputation. So the only therapy we have for this kind of patients is the revascularization by means of both open surgery or peripheral angioplasty, according to the clinical pictures, according to the clinical status of this kind of patients. But there is an important thing, because when you have a patient with rest pain, revascularization means limb salvage. But when you have patients with critical limb ischemia, ulcers, or gangrene, of course, the revascularization is just a part of the treatment. It's just a part, it's not the limb salvage treatment. Moreover, when we have patients with ischemia and infection, it is really important to think about the timing. When we have this kind of patients, the first thing is treating the infection. Even when you have a chronic limb-threatening ischemia, even if the foot is ischemic, think about the emergent surgery, bring your patient into the operating theater, remove everything is infected, because the goal of an emergent surgery in patients with ischemia and infection is to treat immediately the local and the systemic infection. After that, you have to think about the revascularization. After that, we can think about the reconstruction. So I have a problem with the slide. Oh, cannot go ahead. Just a second. Everything is blocked. Can you hear me, Claudio?
Yeah, it's blocked, your presentation.
Yeah, freeze it. Okay.
Okay, now.
Perfect.
Okay.
So this is the first step when you have infection and ischemia. First, remove everything is infected, remove everything is necrotic, and after that, think about the revascularization. Usually, we carry out the revascularization when possible the same day, when not possible, maximum the day after. And even in worst cases, like in this case, where we had ischemia infection, we started with this very bad foot, and we arrived to a transmetatarsal amputation. So these patients at higher risk of major amputation underwent a transmetatarsal amputation. So when we have this kind of patients with infection and ischemia, as I told you, revascularization is a part of the treatment. It's not the limb salvage procedure. The limb salvage procedures are revascularization, timely surgery, offloading, the use of adjunctive therapies like dermal substitute, negative pressure wound therapy, plastic surgery, everything you want. But of course, we have to use all of these strategies, because multidisciplinary approach is important, but also multimodal therapy is important. And I think that you agree with me when I say that the super specialist does not exist. The only way we have for treating patients with diabetic foot is to work like an orchestra. We need to identify a conductor, patients, so difficult patients, patients with a lot of comorbidities, patients at higher risk, not just of major amputation, but also at higher risk of mortality. And this is what we do every day in our diabetes centers, at least in our country. And I would like to support my statement. I would like to demonstrate that this approach works and works very well. And actually, in Italy, in the decade 2001 to 2010, we were able to reduce by more than 30% the amputation rate in patients with diabetes, because we started to work like a team, because we started to do educational in patients with diabetes, in diabetologists, in vascular surgeon, in all the specialties involved in the treatment of patients with diabetic foot. And so I think that my main conclusion is that if we want to achieve the goal, if we want to reduce the amputation rate, we have to work like a team, we have to work together. And one of the goals of the IAWC, the Academy, is to join members of this team and to organize better our work. And so you will be very welcome to Italy. You will be very welcome to ASTI for the IAWC Academy. Thank you for your kind attention.
Thank you very much, Giacomo. How are you? Very, very interesting your speech. And the possibility question and the final of this section. And I call the new speaker, Professor Valerio Cervelli. He is the director of High School of Special School of Plastic Surgeon and director of Department of Plastic Surgeon, Tor Vergata University of Rome. He will speak about the inflammatory ulcers and the role of regenerative medicine in special patients. Thank you, Valerio.
Thank you, Claudio, for introducing me. I would like to thank Dr. Marwan Al-Zaruni and Dr. Sawat for inviting us to give the experience of the Italian Academy of Wound Care here in this fantastic town that is Dubai. And especially after that period of COVID experience, pandemic, that as you saw also from the other speaker, gave us a particular, how can I say, approach to this kind of situation, and as a great problem on the treatment of ulcer all over the world, and especially in the European country, as you saw, because the age of our people is quite high, and I brought here with me two people that are they old, also Professor Ligresti and Professor Bassetto, but they are not the older in Italy. We have a lot of people of more than 80 years, and especially women as an average age major than 80 years. And this is a complication, especially for COVID and for the treatment of ulcer. As you can see from this slide, during the pandemic and COVID-19, and during 2019 and 2020, we had a decrease of the survival of people, especially because of the COVID situation. And that gave us a great problem in the treatment of ulcer, because we had a lot of people in the emergency unit and a lot of people in the intensive care therapy. And as you know very well, this is a major problem from the increasing of ulcer treatment. And so that life expectancy in Italy is very high, but age doesn't always matter. It means that the inflammatory wounds, the autoimmune disorder, especially related also to the COVID situation and to primary cutaneous situation, like all the people that you can see here with a lot of problems, Sjogren's syndrome, and all the autoimmune disease, gave us an altered problem in the treatment of this situation, so that we had an increase of venous ulcer, arterial ulcer, pressure ulcer, and diabetic ulcer. How can we try to play this game? We have a lot of different therapy, dermal substitute, dressing, flaps, and graft. I have to see here from, because I have not the image on my laptop, but the regenerative medicine, in my experience, is the case in the whole that we can use to solve that problem. And regenerative medicine procedure as fat grafting, platelet-rich plasma, and peripheral blood monocyte is a particular, since the last 20 years, are a particular way to solve the problem. The fat grafting is a pivotal technique in both reconstructive and aesthetic surgery, with excellent result and low cost, and with a lot of their efficacy due to the stromal vascular fraction. But we have not a predictable graft survival, and we need multiple procedures. The story is very long, start from Cerny in 1895, and as the last big experience with my friend Dr. Sidney Coleman from New York. In the first 90, we demonstrate together that these people treated with fat grafting as not only a sort of whole replacement, but more and more as an advantage in the quality of skin and in the quality of tissue. It means that fat grafting has not only the immediate filler effect, but most and more as a long time biostimulatory effect due to the adipose-derived stem cell. That is the topic of our application in this field, because as a mesenchymal cell with lipoblast and the pre-adipocyte and adipocyte connected with different pathways, not only in the adipogenic and mesodermic ways, but also to other cellular lines like neurogenic, angiogenic, and hepatogenic. It means that is a real solution, is not a fibrotic cicatrization, but is a regenerative tissue enhancement, and has also an autoimmune and anti-inflammatory effect. So that adipose stem cell are supposed at this point to be the star in fat grafting, but as demonstrated by Patricia Zack, the adipose tissue is the major source of mesenchymal stem cell in our body. But how did they came into display? That is very important. The solution is the adipose-derived stem cells that are part of the stromal vascular fraction, that is located in the perivascular niche, so that is ready to come into the play from the microvascular engagement, with different criteria to define what as adipose-derived stem cells and how they work in terms of differentiation, but also secretion and self-renewal. And their action in the chronic wounds is quite complicated, because it's not only a direct differentiation and substitution of cells, but also a paracrine effect with anti-inflammatory and endothelial and dermal fibroblast substitution. We have a growth factor release with an endothelial differentiation due to the quite near location of the cell in the place where they have to act, and they have an angiogenic production of vascular endothelial growth factor that stimulates the proliferation of that endothelial progenitor cell that they are thought to be the producer of platelet-derived growth factor and other mediator that promote migration and differentiation of this adipose-derived stem cell with an antifibrotic activity, as I told before, is not a fibrotic scar. cicatrization, but is a fibroblast activity suppression. It means that our goal, the goal of this cell, is to reach a real regeneration of the tissue and not a substitution with scar tissue. That is not what we want in this case, with an anti-inflammatory effect that is thought to be the regulation of the anti-inflammatory cytokines. And the case is the activation of M2 macrophage that are the most important actors in this game, because the M1 macrophage, as everyone knows, has a pro-inflammatory effect, but we are told to be interested to this M2 macrophage with a pro-angiogenic and anti-inflammatory activity through a very complex polarization of the M2 that are not destructor, are not inflammatory agent, but anti-inflammatory agent with the debris removal, with a regulatory effect, and with a pro-angiogenic anti-inflammatory activity. And they are supposed to go in the M2 situation to solve the problem of the wound healing through as I told before, the lipostructure in this case. You can see some activity of this cell. But how to improve again this fat grafting effect through a tissue engineering, through the use of fat grafting and PRP gel in the various situations, alone or together with the pro-angiogenic medication. And in all these cases, we use the both lipostructure together with PRP application. Since a lot of years, as you can see from this work of the 207 of my group in Rome, the fat grafting plus PRP in different situations after the time protocol, fat graft, vaporization of PRP, or PRP in the solid situation. So that let's arrive to the anti-inflammatory effect of these drugs. The systemic sclerosis is the most frequent autoimmune lesion that we can observe in our activity. And also in this case, the use of regenerative approach through fat grafting and PRP gave some really important results, as in the concept of regeneration of my friend Gino Rigotti in Rome, this classic work for the treatment of radiodermitis that is also an inflammatory situation that we can solve with the use of fat graft and stem cell. But how to improve this fat grafting effect? The solution is the cell-assisted lipotransfer. But as you know, in Europe, we have some limitation for the extraction of stromal vascular fraction for the lipoaspirates. This is not correct. We are enzymatic technique. The collagenase use the Cytori system, but is not more allowed in the European community to use the enzymatic extraction of stem cells. So that we have to use the mechanical filtration, the non-enzymatic technique that has even a composition of stromal vascular fraction very important. The mechanical technique is faster, cheaper, and more practical, but with a lower cellular income and then a higher cellular dispersion, so that it works together with yellow matrix, yellow silver, and other medication. The other application that we use in our study is the peripheral blood monocyte extraction. That is the third weapon that you have against to enhance the wound healing. And even we came back to the use of M2 macrophage for the tissue regeneration. These are the main function of macrophage. with the circulating macrophage and the extraction from the peripheral blood and washing of the M2 macrophage that we used in the, after curettage for the infiltration through the vascular tree to enhance the limb salvage technique. In conclusion, regenerative medicine is a useful technique in inflammatory ulcer. Obviously, we need a lot of further research to define which one is the best anti-inflammatory and regenerative effect, and especially a multidisciplinary approach of this patient is always necessary. And this is the direction of the Italian Academy of Wound Care research in this field. Thank you very much for your attention.
Thank you, Valerio Cervelli, Professor Cervelli, for your interesting presentation. And now, to conclude our section about the IAWC Wound Care, Italian Academy of Wound Care, I introduce the last speaker, but not the least, Professor Franco Bassetto. I spoke about him. He's the director of plastic surgery, University of Padua. He will speak about the physical therapies, because the physical therapies is including sometimes in the concept of regenerative medicine. And so, Franco, for you, your presentation.
Thank you again. In the introduction of this meeting, the president of the meeting subtitled the importance of technologies nowadays in their interaction with plastic surgery. Surely, in our recent experience in Padova in clinic, we change a lot our surgery, putting it together with technologies and physical therapies. And I hope if you will ask to be part of the Academy of Wound Healing in Italy, trying to stay with us for this period of training, you have the possibility to see in different universities how these technologies are used nowadays and how they are changing the plastic surgery approach. So we know that with the term of physical therapy, we refer to the interaction between the wound and a physical system in which there is a transfer of energy to or from the wound, which in turn translates into observable and measurable modifications in the system as well in the wound. So if we look to the main physical therapies that were used in the last 10 years, we can see that negative pressure, that other kinds that we will see are considered nowadays from the EUMA meeting, that it's the group, or the European group of wound healing, the most important step in wound healing of the last 10 years. First of all, which is the queen? Negative pressure. We know that negative pressure really changed the plastic surgery approach in the last century. Nowadays, we have 25 years of experience, and exactly not 10 years ago, in another meeting here in Dubai, we tried to understand which was the evolution of negative pressure in these 25 years. A lot of things changed from the beginning when we understood that the power of negative pressure was the contraction of the margins of our wound related to the microenvironment stabilization. This was really the revolution of negative pressure, because through this technology, we understood that we had a huge removal of phlogistic mediators like matrix metalloproteases that we know are the really key related to the fact that the wound healing is not possible and we have a chronic wound. Then we have an activation through the kinesis of the mitogen activity of every cell that is under negative pressure, with an important reduction of bacterial load. This is the third result that we obtain using negative pressure, related to the fact, especially in the last period, that we are using negative pressure with instillation. The other important power of negative pressure is the edema reduction. And like Dr. Ligresti told, in such patients with chronic wound that we have to consider phlogistic patients, patients in which we have a general inflammation, systemic inflammation, it's very important, the locally edema reduction, related to the fact that through negative pressure, we have reduction of exudate and interstitial fluids, reduction of hydrostatic and osmotic pressure, and a stimulation of capillary blood flow. Every one of us, when we use negative pressure, we see that our chronic wound change from yellow color, from green color, from gray color. It changed in red color because we have a lot of neoangiogenesis. And then related to angiogenesis, we have a wonderful enhancement in tissutal oxygenation and in reepithelialization. This is the reason why negative pressure was considered the queen of the physical therapy related to wound healing. And in this important paper that we publish in JPRAS, we try to understand which is the histological evolution of chronic wounds under negative pressure therapy. In simple words, it's a reactivation of a chronic procedure in an acute procedure to prepare the best wound bed that we can have for plastic surgery procedure. And which was the last frontiers of negative pressures. They rule in severe lymphedema. Like you can see here, this was a child that have a very important lymphedema after a banal trauma, and she can't use his feet. So we decide to do an incision, to use negative pressure, and then when we had the lymphedema resolution, it was very useful to use a skin flap, a simple skin like transplant, like you can see here, and the lymphedema problems was solved. So the rule of negative pressure must be considered in lymphedema for its application in the future. Or the use in multi-drugs resistance patients, like this one, that was an obese patient that went through a mega abdominoplasty, in which unfortunately we have a multi-drug resistant related to Serratia marcescens. And using negative pressure with instillation, we have a negative Schwab's after 1 week of treatment. So we think that these would be new steps of negative pressure through the future, especially when you use the new proposal, the so-close wound cleanse dressing, that is a 3-layer dressing featured by a high tensile strength. It's less hydrophobic, promotes wound cleansing option, and offers a quick and unfaithful debridement. The company proposed this at the beginning for the treatment of debridement in non-surgical patients. Nowadays, in our experience, we think that is a very clever interface that through it tools give the possibility to change in a shorter time the condition of the wound bed, arriving even to spontaneous reepithelialization. So it facilitates removal of thick exudate material, fibrin, slough, and thick wet exudate and other infectious material, and can be used not only when surgical debridement is not possible to do and must be delayed. Now we are using it a lot. And here you can see how it changed in a very short time. And the diameter of this hole permit to obtain gems of reepithelialization that sometimes go on and arrive to a spontaneous reepithelialization. So in a huge chronic situation like this one, in between 7 and 10 days, we can arrive through a spontaneous healing, or at the best wound bed that is ready for a simple solution of plastic surgery. The other technology that was proposal in the interaction with our wound, the physical therapy, was the closed incision negative pressure therapy. That is the same concept of negative pressure that we put on the closed incision. And through the negative pressure, we can obtain a better quality of scar, an easier post-operative management, preventing diastasis, preventing complication, control of the local inflammation and exudate, and a reduction of complication in high-risk patients. Here you can see two different physical therapy. One is PICO, that is very, very useful nowadays all over the world. The other is Prevena, two different companies that propose the same concept. Negative pressure, low AT. It maintains MPT on surgical closed incision for 7 days, removes the exudate from the wound bed by absorption and evaporation, and it has a high compliance of the patients. It's very used to wear this incisional negative pressure when the patient is at home, not in an hospitalization assessment. And we try to understand its power, for example, in post-bariatric surgery, in which we know that unfortunately the scar in brachioplasty are not most of the time good scars, and our patients are unsatisfied about this because it's in an area that it's very, very fragile. So we try to compare the same number of patients. The first group in which we use PICO system, incisional. The second in which we use the traditional garments in brachioplasty. And our experience was, as you can see here, you put PICO on the wound, closed wound, and you maintain it for a long time, for 7 days. We arrived to a better scarring. Then technologies on negative pressure are going on, and we are using the single-use negative pressure therapy that is very clever because you can put it on patient at home. It stays for 1 week, and it gives good changing in the wound condition like in these chronic patients. Another therapy that has in the last period an important steps all over the world was the so-called acoustic shock waves. The acoustic shock waves must be considered physical and biophysical therapy they are not ultrasound. They have a cavitation effect that are nowadays using in very, very huge wound healing. Patients with, it's a second choice. And what is its power? The possibility to give a neoangiogenic effect, an anti-inflammatory effect, arriving in vascular ulcer and mixed ulcer after long time, 2 months, 3 months, to arrive to resolve the problem. And the last one in which I really was from the beginning involved by a Montreal company that was called Clocks, is the fluorescence light energy. It's called FLE, And it's surely a new proposal in the balance between wound healing and scar control. We know that if we have the best wound healing, maybe we will have the best scar in our patients because we reduce the inflammation period. And fluorescence light energy is based on the unique ability of light accepting molecules, chromophores, to translate light emission from a lamp, that is a blue lamp, in a different photons emission with broader wavelengths, spectra, and lower energy fluorescence. And you can see that we have different specific wavelengths at different colors that have different biologic effects in terms of modulation of inflammation, fibroblast proliferation, collagen production, modulation of growth factors, and antibacterial effect. And we had a use experience with this device during the pandemic period in all patients because it was very, very simple to use this technology. And I have seen it even in a stand to the exposition to the Dubai Expo. So we are really convinced that it's an advanced physical therapy because it acts at all levels of different cells that we have in our wound. But which is the secret of this powering energy? The possibility that it acts on mitochondria. We know that mitochondria are like the inspiration of our cells, the inspiration site of our cells, and the power is directly on mitochondria. This is the reason why the mitochondria are source of cellular energy responsible for the control of cellular stress, and they are involved in many diseases such as diabetes, connective tissue disease, and so on. We concentrated in our research group the observation, and we saw that treating these patients with FLE, we have an increasing number and dimension of mitochondria, of dermal cells, an increasing number and dimension of mitochondrial crest for ATP production. So our basic researcher gave to us, to our clinic team, the answer to our question: what is the power of this light? The power is the possibility to give now angiogenesis. This is the one of our publication on this line. The possibility to product and reorganize the collagen fibers. And as plastic surgery, we know that the organization of collagen is very, very important. The possibility to reduce the myofibroblasts activity with a consequent better scarring. So trying to go to results here, you can see, for example, that in these patients with a chronic wound post-oncological excision and flap reconstruction, like we have seen in the first lecture of our colleague from Paris, using this FLE therapy, we have even in these black patients an evolution of melanotic cells, as you can see here on this site of reconstruction. And this enthusiasm know a lot. We had an Eureka study that was an Italian study in which we saw the power of this in the so-called Italian research project in which we understand the power. So arriving to the end, now we are using it on burns. This is new to control the post-burn patients and to control even the spider bite, that is another chronic condition. So really, we are convinced that the future will be interaction between physical therapies and new physical therapies that are now ongoing and plastic surgery. Thank you very much.
Thank you, Professor Bassetto. And of course, the physical therapies are the skills for us to treat the wounds. But we have a few minutes to discuss about the presentations in these sections. And I remind you about the COVID problems, the causes of COVID skin lesions. I spoke, I was spoke mine personally. And the second was the pressure ulcers by Professor Bassetto. And third, the diabetic foot of Giacomo Clerici. And post was the inflammatory ulcers, and finally the physical therapies. Any question from the audience?
Hi, I'm Dr. Marwan Al-Zaroni. I have a question. Thank you, first of all, for our international speakers to present all these tremendous, great presentations. I have a question. How do you do for the whole group? How do you do the selection of the patients for different type of treatments? Because some of you decided about the negative pressure, others they were saying about the dressing, and then the last presentation, it's a combination of light treatment, shock waves, and negative pressure. So how do we do the selection? Which patient will be better for what?
I think the right question is that everything. We have a multidisciplinary approach to this kind of patient with a large protocol, and is necessary in this kind of branch of medicine, regional medicine, that is a relatively new approach. The problem is the lack of wide casuistic, wide study, so that we need to have a multidisciplinary approach with all the different technique to this patient. The question could be which one before and which one after. And I think altogether they give the result. The dressing obviously is very important. The negative pressure in all these patients, especially in different phase of the treatment of the scar. In the first time, just after the debridement, we need to have first of all approach through the negative pressure. Then after, when the scar is going to solution, we have to improve the management of the situation with the regenerative medicine. And in some case, when we have large defect with bone exposition, probably is necessary to do a limb salvage through a free flap. But it doesn't mean that we cannot use regenerative medicine on the free flap. Just in last time, my group in Rome used to do recharged free flap. It means that we can use adipose-derived stem cell and cell enriched transplantation in the free flap that is charged with stem cell. And this could be the future also in case like this one.
Okay, thank you. My last question, I don't know if the message is correct. In some of the presentations showed that we are able to apply the negative pressure on cancer patients.
First of all,
So I need to make it clear for everybody
yes,
here,
yes.
because this is a little bit...
Yes. I thank for your question, and I think that at the beginning we considered that plastic surgeon would use the best technique, a simple skin graft or a complicated perforator flap to every patient. But now times are changed. We think that a plastic surgeon must consider even technologies in his knowledge, because we know that the patients with chronic ulcers, like Claudio told, are inflammatory patients. So we must use technologies that can control the inflammation condition. So it depends from a lot of things which kind of solution we can use. A good advanced dressing, it's a good solution for a chronic patient if it's it is in a non-on hospital setting, if it's at home. But if you have technologies and you can use them, and you can arrive to better solution, simpler solution, if you control the inflammation moment with technologies. So I think that the future of our role as plastic surgeon will be this, not only to be the people that choose the right technique for the patients, but even which technology can do a simpler solution. Negative pressure was the main revolution, surely, and it's important to remember that its power, it's neoangiogenesis. So neoangiogenesis could be a very, very dangerous solution in cancer, because if you have neoangiogenesis on a cancer that was not completely treated, you must have wedge margins with no cancer present. In such kind, you can use it. You can't use if you have still cancer.
Okay.
I have a comment, please.
The last question.
Yes.
Thank you.
I'm Dr. Kadri. I'm professor of plastic surgery at Cairo University. I want to simplify the answer to which Marwan actually put on the table. We should remember that you are a tertiary care center. So what you are presenting is very attractive, but this does not necessarily mean that it can be applied anywhere. You are the top of the notch. Meanwhile, you cannot treat all the patients who are presenting with these problems, and simpler methods of treatment are always available at a lower level. You are lucky because you are working as a group, and this is something we are missing in different parts of the world, even if you have financial resources. A group functions in the best interest of the patient. A single practitioner works in his best interest. He's trying to implement what he thinks is better or what he is practicing to make more success to his practice. However, I was very impressed about the light and the fluorescein and all that. But nevertheless, those are waves that come every 10 years. And they don't stand the test of time. They vanish after some time and something else will appear. So for the younger generation, I'm no longer young, unfortunately, but we should be cautious about taking this into consideration. The basic guidelines, the protocols, as you very wisely put it on the table, are the most important thing nowadays in all practice in medicine. So we should not transgress. We should make sure that there is no cancer. Elimination of cancer should come first, before coverage, before. I agree with you 100%. I am reviewing a lot of articles for the Egyptian Journal of Plastic Surgery. Negative pressure is taking new horizon every day, closing the dehiscent wound of mammoplasty. A lot of things. It has not ended. The disposable apparatus. And even in our part of the world, there are innovations. You don't need the big companies to do it. People are improvising things of the kind. We are lucky to have you today with us. We share with our northern Mediterranean neighbors their experience. And believe me, if you share with you the improvising what we are doing in our part of the world, you'll be happy that we are gathering with the same aim. Thank you very much.
Thank you for your considerations. And to conclude this section, we have learned a lot of situations. But the first problem for us, and I mean for the academy, is the diagnosis, the assessment. The assessment is the first important point. and the last, and the later, the treatment, like Professor Bassetto, Professor Cervelli, and Giacomo Clerici spoke about the different treatment, the multidisciplinary treatment. And so, to conclude this section, I like to call my colleagues, my Italian colleagues on top, and the Professor Marwan, the president of this Congress, to formal pass, to formal donate some gifts for you and for Dr. Savat that is not here because has problem, and for you and honorary member for IAWC, and a little gift of Italian fashion. Huh?
Thank you very much. Thank you. Thank you for having me here. Thank you. Thank you.
Bye. Okay, and so coffee shop, coffee time. Thank you.
Instead of 20 minutes, we'll have a 15 minutes of coffee break. Thank you very much.
Recording stopped.
are my friends.
Hello, mic check. Thank you so much. I welcome back you all. Hope you all enjoy your coffee and your snacks. I now may please welcome Mr. Atif Imam to address the gathering. Mr. Atif Imam, please.
Bismillah ar-Rahman ar-Rahim. Dear Professor and colleague, first of all, I want to thank Professor Marwan, Professor Kahtani, and Professor Safwat al-Husseini, and also the organizing committee for these generous invitations. And also, I would like to express my pleasure to give us the chance for participating in this marvelous conference and exchange our information and view across the world. First of all, this is an Egyptian sessions. Also, it is a military Egyptian session. All of them are had a military ranks. First one, it's an honor to introduce Major General Tarek El-Menoufi. Tarek El-Menoufi is a senior consultant now of the Egyptian Armed Forces. He's the director of one of the biggest hospital in traumatology. He's the medical directors of Armed Forces Hospital in Hilmiya. He will speak about the use of dermal skin substitutes for post-traumatic and post-burn scar revision. Professor Tarek.
Thank you. Thank you, my professor, Dr. Atif. Dr. Atif is my professor, actually, and I would like to thank him very much for this kind introduction. And I would like to send my gratitude and thanks to the organizer of this committee, Professor Marwan, thank you very much. And Professor Safwat, we miss him very much in this meeting. And also Professor Kahtani for this invitation for this conference. Bismillah ar-Rahman ar-Rahim. My talk today is about the use of dermal substitute for post-traumatic and post-burn scar revision. This is the Armed Forces Burn Center in Hilmiya Armed Forces Hospital where I work. Skin substitutes are a heterogeneous group of wound coverage material that aid in wound closure and replace the functions of the skin either temporarily or permanently, depending on the product characteristics. Application of skin substitute dates back to the first written report on skin xenografts in the 15th century BC. The clinical use of a human skin allograft was first described in the manuscript of Branca of Sicily in 1503. In 1880, when Joseph described an absorbent dressing made of cotton wool sandwiched between layers of gauze. In 1895, Mangold described a technique of epithelial cell seeding as a way of treating chronic wounds. In 1897, Logren recounted that fragments of skin can be kept alive when inoculated in anesthetic fluid at room temperature. Various skin substitutes were tested over time, such as a human skin allograft, xenograft, amnion, are still being used at various burn centers all over the world. With the advent and progress of biotechnology and tissue engineering, a wide area of skin substitute is now available in the market for treatment of burn injuries. The ideal skin substitute should have the following criteria: able to prevent water loss and able to resist infection, also has the ability to withstand tissue hypoxia. Lack of antigenicity is very important, And also it can be conformed to irregular wound surfaces and easy to be secured and applied. It is able to withstand shear forces and has a flexible in thickness and durability for long time and wound stability. It should be cost effective and widely available, long shelf life and easy to store, but unfortunately, to date, there is no what's called an ideal skin substitute available that fulfill all the above mentioned features. Currently, tissue engineering and biotechnology are gearing towards the direction of creating an optimal skin substitute. There are various ways to classify skin substitutes, either according to the layer to be substituted, maybe epidermal, dermal, or compound of both, or according to durability, either temporary or permanent, and according to the product of origin, either biological, biosynthetic, or synthetic. From the practical point of view, the skin substitutes are best classified as temporary or permanent, and synthetic or biological. As an example, we have the BioBrand, started in late 70s, and it is now widely used as a temporary skin substitute. It consists of a nylon mesh as a dermis and a silicone membrane as an epidermis. Both are embedded in a porcine collagen. It's mainly used for superficial and mid-dermal partial thickness wounds and burns, and also it can be used over donor sites. BioBrand versions are, it is ready availability, low pain, short hospital stay, accelerated wound healing. However, there is risk of infection. The Alloderm, another example, is a dermal substitute, is essentially formed of a cellular matrix derived from a cadaveric dermis. The allodermis is processed by salt to remove the epidermal layer and then extracted with a solution to remove any cellular material. It is then freeze-dried to render it inert immunologically, although its basement membrane remains intact. It has no epidermal layer. However, the acellular matrix provides a good natural medium for fibroblast and endothelial to regenerate from the new dermis. The TransCyte is similar, again, a tissue-engineered skin substitute made of a nylon mesh and a silastic, semi-permeable, and biocompatible layer. Allogenic fibroblasts from neonatal foreskin are embedded in a mesh and allowed to grow for 3 to 6 weeks to produce a cellular matrix of collagen and growth factor, which may enhance wound healing. It is left in place until either spontaneous separation occurs, which indicates wound bed healing, or the wound is dealt with surgically. The Dermagraft is similar to TransCyte, but it lacks the silicone layer and also contains viable fibroblasts. It is produced by mixing the living neonatal foreskin fibroblast with a biodegradable mesh from polyglycolic acid, which is Vicryl or Dexon, in a bag with circulating nutrient. The polyglycolic acid mesh is absorbed within 3 to 4 weeks. It can be used as a temporary or permanent coverage to support the take of meshed split thickness skin graft or excised burn wounds, chronic wounds, and even in diabetic ulcers. The Abligraft is a bilayered living skin equivalent composed of type 1 bovine collagen and allogenic keratinocyte and neonatal fibroblast. It has to be applied fresh as it has shelf life of 5 days at room temperature. Abligraft has been shown to be accelerated or wound closure. It is indicated in partial to full thickness burns, skin graft donor sites, also in chronic wounds and diabetic ulcers. Abligraft, when combined with autograft, has produced more favorable results than autograft only. Scar tissue, pigmentation, pliability, and smoothness were significantly close to normal with Abligraft. Now, Integra, which gained much popularity, widespread use in the clinical treatment of deep partial thickness and full thickness burn wounds, full thickness skin defects with different etiologies. It is a bilayered skin substitute made of a silicone membrane as epidermal layer. It is important to water. It is impermeable to water and protect against infection. The dermal part is made of a bovine collagen and sharp chondroitin 6-sulfate glycosaminoglycan. After coverage, the wound becomes revascularized within 2 to 3 weeks. At this stage, the superficial silicone layer is removed and replaced by a very thin split thickness skin graft applied onto the new dermis bed. The advantages are immediate availability, allowing time for new dermis formation, good aesthetic results, and less contractures. The disadvantages are needs two-step operation, being expensive, accumulation of exudate underneath may lead to infection. Finally, the Belnac, it is another dermal substitute like the Integra. I will show some cases from our experience in the Integra. This is the ideal appearance of the Integra, the day 0 after application in the theater with red color. Then it starts to change within 2 to 3 weeks until it reaches the mahogany color and the shrinkage of the silicone layer, which indicates that this silicone layer can be removed. I start by the case number 1. This is a 43-year-old male patient with severe contracted like thumb post-electric burn. This position of the thumb is not suitable for function. He has no opposition. And so we think how to solve this problem for this patient. And we decided to excise the scar, put the skin substitute Integra in to fill the defect. And then we put a Kirschner wire to put the thumb in the proper functioning position. Fortunately, we have this picture early post-operative with good response. And this is after 3 weeks with good take of the dermal substitute, and shrinkage of the silicone layer indicates it's time for removal. We removed and we put a thin split thickness skin graft, and this is early post-operative. And this is the second post-operative dressing with good take of the graft. And this is after 2 months. We can see that the patient has a good take of the graft, and we removed the Kirschner wire at that time, and the patient had good opposition of his thumb, better than the early contracted post-burn scar. Another case, 20-year-old female patient with a hypertrophic scar post-burn. This is a huge scar, limited the movement of the axilla. We decided to excise this part of this scar and apply the Integra over the defect. And this is the dressing over 4 weeks until we reach this mahogany color, and we removed the silicone layer and applied the split thickness skin graft. And this is the picture in the first dressing and after 2 weeks with good take of the graft and more movement of the axilla. This is an example of a 30-year-old male patient with a hypertrophic scar post-burn, limiting the movement of the wrist and the flexion of the fingers. And we again decided to excise this large hypertrophic scar, put a dermal substitute that's Integra, and wait for 3 weeks, and then we remove and put a split thickness skin graft, and this is the result. This is a case of a 21-year-old male with a fingertip injury to the right middle and ring finger with exposed distal phalanx and flexor tendon. We try to preserve the length of the fingers and preserve the tendons as well. We decided instead of using a local flaps to put an Integra on this part. And fortunately, the Integra taken, and after 3 weeks of dressing, we reached that we can remove the silicone layer and put a split thickness skin graft. Unfortunately, the graft takes, and this is the result. We kept the length of the finger and kept the movement of the finger as well. This is one of the difficult cases, a 43-year-old male patient with a blast injury result in open fracture of lower third left tibia, has a compound fracture tibia with a contaminated comminuted fracture. This case, usually somebody will think we try to debrine and fix the fracture and put a free flap, because lower third of the leg is a very difficult site for coverage. Again, we decided with our colleagues, orthopedic surgeons, that we put an X-fix to fix the fracture, and we do an aggressive debridement for the wound, and we reached this level. Then we decided again to put Integra over the defect, which was created after excision of the dead tissue and debridement. We follow the Integra till early post-operative. This is a good result. And this is late post-operative after shrinkage of the silicone layer. And we end with this bed of granulation tissue after 4 weeks. Then we decided why we don't put a skin graft. We put a split thickness skin graft, and to enhance the take of this graft, we added the VAC to increase the blood supply and reduce the size of the defect and increase the possibility of the take. Fortunately, we have a good take of the graft after 3 dressings, And this is the results. After 6 months, we have an acceptable scar, and the patient can walk with a crutch on his limb. And we thought that we solved this problem with a minimal solution, keeping the muscles or the free flaps for the patient, decreasing the morbidity of use of such flaps. Again, another case, 23-year-old male patient after road traffic accident with exposed middle third tibia. Again, it is a case for why we don't use we have the gastrocnemius and the muscle flap, or we can use the soleus muscle flap for the coverage. But we think why we don't save these muscles for him, and we decided again to put a dermal substitute over the defect, and this after 3 weeks, good take of the dermal substitute, and we applied again a thin split thickness skin graft, and this is the result after the first dressing and after the second dressing with good success of graft take, and again we saved the muscle for the patient. He can save the function of this muscle. Finally, a 22-year-old female patient with a neck contraction post-flame burn. Neck contraction is a difficult task to manage, especially in a female, because usually we have a bad cosmetic appearance of the skin grafts. But the patient refused to use flaps, and we decided to excise this skin contraction, put the dermal substitute, and put a skin graft, and this is the final results. I think with the accepted scar and good movement, extension, flexion of the neck. In conclusion, skin substitutes have an important role in the treatment of deep dermal and full thickness wounds of various etiologies. At present, there is no ideal substitute in the market that provides an effective and scar-free wound healing. Dermal skin substitute is used in treatment of post-traumatic and post-scarring, complete excision of hypertrophic scar with subsequent implantation of dermal substitute for defect closure. Split thickness skin grafts of the new dermis is performed 3 weeks later. Comparison of the pre and post-operative results revealed a significant functional and cosmetic long-term improvement, which suggests that dermal skin substitute is a valid treatment modality for post-traumatic and post-burn scar vision. Further research should be carried out, not only to compare different skin substitute, but also to evaluate new biological and synthetic material that can be utilized in wound healing. Thank you.
Thank you, Professor Tariq, for your marvelous presentations and your excellent results. Thank you so much. Okay. Now may I introduce Professor Hani Saad. He is a professor and consultant of plastic and reconstructive surgeon in Military Medical Academy. He is also Major General, and he is the head of the department in El Gala Military Hospital. Professor Hani, he will speak about slide swing flap in reconstructing meningococcal defect.
Thank you.
Meningocele defect.
Yes. Thank you. At the beginning, I would like to thank Professor Dr. Safwat Al-Husseini and all the organizing committee, the president of the conference, for their kind invitation and their hospitality. Really, I appreciate it so much. Ladies and gentlemen, dear professors, dear colleagues, I'm honored to be with you all today, and my presentation will be on slide swing flap in reconstructing a meningocele defect. I would like to thank one of my colleagues at Galat Military Complex, Professor Dr. Jamila Kafoufi, which is a consultant pediatric neurosurgeon, and she did the neurosurgical part of meningocele. Actually, meningocele is a type of team approach management. We approach it as a team approach, part by the neurosurgery department and part by the plastic surgeons and part by the pediatric follow-up if they need any follow-up in the pediatric department. And I would like to thank the medical and paramedical staff at Galat Military Medical Complex. Meningocele is a congenital malformation arising from an error in the CNS development, particularly the spinal cord and spine. It's an outpouching of the spinal cord covering with the defects in bone and soft tissue covering of the posterior aspect of the spine. The sac is usually filled with CSF and lead to bulging mass on the back. The malformation might include spinal nerves, and this is called meningomyelocele, but our concern today is with the meningocele, which is deficient of any contents rather than the CSF. The malformation is due to abnormal development of the outermost covering, dura and arachnoid. The normal development, the nervous system development from the plate of cells, neural tube. Okay. The normal development, the nervous system developed from the plate of cells, which is called neural tube. If the lower end of the tube does not close normally, it can lead to various forms of spina bifida with various severity. The mildest form is called spina bifida occulta, and the mid form is called meningocele, and the severest one is the meningomyelocele. And here you go, the types of spina bifida occulta is the least obvious and the least serious one. If you could hardly find it with, usually clinically, it appears with tuft of hairs on the back of the spine. And most people never become aware, I mean the parents never become aware of this condition except lately. And the meningocele is the next most serious type. We find the meninges pass back through the opening in the spine to form a cyst-like swelling. If this sac contains spinal nerves, this or part of the spinal cord, this is called meningomyelocele and considered to be the most severe one. After the neurosurgeons finish their job by reducing such sac and reducing the contents if they find any, we come to the role of plastic surgeons. Usually they call us problem solvers. Usually they name us the finishers. This one of the team approach, as I mentioned before. We have to reconstruct the defect remaining after reducing such a meningocele. Here an example with meningocele and thereafter transpositional flap. The slide swing flap depends on a transposition and skin sliding. So we have the flap could be, the transverse dimension could be smaller than the defect itself. So we have two advantages. We could reconstruct like with like. We could reconstruct the defect with the same tissue, and in addition, we could use solve the large defect by making undermining surrounding the defect, and then finally the flap could swing inside or could be swung inside the defect to be closed. So it's based on transposition and skin sliding of the skin surrounding the defect. Outline the meningocele and put the expected defect in either one of three forms, either a rounded one or oval one or hemispherical shape. Type 1 with an rounded defect, and then we could transpose the flap after making undermining of the tissues surrounding the defect, and then insetting the triangular flap at the donor site, and then finally we close it after swung of the flap. Type 2 with an oval defect. Same by making the defect in a hemispherical, that type 3. This flap is dissected and swing into the defect and then closed in 2 layers. Another advantage is we don't put a drain without skin grafting. All the patients were presented and operated upon at Al Gala Military Medical Complex across 6 years, from 2015 till the end of 2020. The patient were 8 boys and 2 girls, 10 in number totally. Their age was ranging from 1 to 3 months. Well, I and my team and the neurosurgical team prefer the age to be at 1 month age, not immediately after. Why? Because immediately after delivery, it was found that the skin itself is not well vascularized, and we might face an element of partial flap necrosis. So the better timing to operate upon is between 1 month and 3 months age. And the pediatric consultation to arrange for post-operative special care if needed. From the complications, the 8 of the patients showed no complications. Only 2 patients showed complications in the form of infection with wound dehiscence at the slide or the picture above, and CSF leakage and wound dehiscence in the slide below. Treatment of complications, we use to take a swab for culture and sensitivity and test for CSF leakage, and neurosurgery do a peritoneal shunt to decrease the pressure upon the flap, and local applicants in the form of betadine alginate-based gels. Here you go, some clinical cases. First child, 1-month-old boy with rounded meningocele, 7 centimeters in diameter. Slight swing flap is marked, and you could see the diameter of the transverse diameter of the flap is less than the original defect. Flap insetting in the rounded defect and closure in 2 layers. Complete healing after 3 weeks post-op. Another child, 1.5 months, presented with rounded meningocele, 5 centimeters in diameter. Here, the marking of the flap. Here's the defect after. We use type 1 of slight swing flap with the rounded defect. Here, after insetting of the flaps, closure in 2 layers, first with absorbable 4O vicryl and the external one with 4O proline, simple interrupted. Here, this child showed 2 weeks post-operatively a wound dehiscence, but totally healed after 4 days post-op on conservative management without further surgical intervention. 2-month-old boy with large oval defect and large meningocele. Coverage needs 2 flaps, slide swing, and modified rhomboid flap, which we call deformental flap. Insetting of the 2 flaps and closure in 2 layers. We faced CSF leakage after doing a shunt by the neurosurgeons. And here you go, complete healing after 7 weeks post-op. Another interesting case, usually I face, or in our practice where we have seen a lot of patients with meningocele at the lumbosacral, at the dorsal regions or thoracic regions, but rarely we could find a cervical one. A 3-month-old with meningocele in the cervical region, marking of slight swing flap, 4 days post-op, 2 months post-op. Another child with large oval meningocele, marking of slight swing flap. You see how it was large flap, insetting of the flap and closure in 2 layers, 3 months post-op. Another girl, here after finishing the neurosurgery job and the defect and the insetting of the flap. 8 of the patients showed no post-operative complications, while 2 patients showed infection and CSF leakage. Cases were followed up during their hospital stay and continued for few months thereafter. We usually use conservative management after wound healing in the form of scar management. We use silicone gel and silicone sheets to reduce scar and make it, as far as we can, less obvious or inconspicuous. In conclusion, slight swing flap is a reliable problem-solving flap for closure of meningocele defects. And my message, in cases showing wound dehiscence post-operatively, don't rush and do second surgery. Be patient and wait for these cases is going to heal without further surgical intervention, and the parents will be grateful. Thank you very much for your attention. Thank you very much.
Thank you, Professor Hani, for your very nice presentations. Now I introduce myself. How can I use? Right, next, okay. Sorry, because Professor Tariq Ata is difficult to attach with him. Okay, I will start. First of all, I repeat my thanks for the organizing committee, especially Professor Marwan and his colleague. So difficult to speak about pressure ulcer after Professor Bassetto. Thank you very much for his knowledge that I gained from him. And I will speak for another issue. I will speak about from journey, from prevention to surgical intervention. So we'll start from the first. My agenda is I will speak about definition, incidence, etiology and pathogenesis, risk factors, care plan, screening, prevention, preventive measures, assessment and staging, adjuvant measures, and surgical intervention. What is the ulcer? What is it? By National Pressure Ulcer Advisory Panels, they said that they defined it as a localized damage to the skin and the underlying soft tissue, usually over bony prominence. Also, occur as a result of intense or prolonged pressures. Also, that may be present in intact skin or open ulcer. So, the debate now is what is the name? Is it pressure ulcer? Is it Decubitus ulcer? Is it pressure sore? Or is it injury? So, by histopathological work, a small changes in pressure-related injury start in the tissue before any visible changes. So is it an ulcer? No, the ulcer is a break in skin or mucous membrane. So it's an injury because we can see it before any visible changes in the skin. There is a lot of studies about the incidence, but the incidence and the prevalence vary and related to the facility, underlying medical conditions, and the age of the patient. We have a lot of studies about the incidence, but overall global prevalence of pressure ulcer using about 14.8%. and a meta-analysis reporting on the incidence of the pressure ulcer presentation in an emergency department was 6.31. So it's so common. What is the etiology? We have a mechanical causes, we have intrinsic causes. Mechanical causes, pressure, shearing forces, friction, and intrinsic causes, immobility, poor circulation, thick, fragile skin, urinary and fecal incontinence, and infection. Also, sustained pressures, as you said before, lead to the pressure ulcers, maybe in combination with shear and friction. From this table, we can find that the external physical pressure, as in bed with shears, also shearing force. What's shearing force? Shearing force is mobilization of the under tissue over the under the fixed skin. So it can angulate the vessels and can lead to the thrombus formation and ischemia. Also friction between two objects. Okay. Incontinence, moisture, limited. All of this lead to the unrelieved pressure greater than arterial capillary pressure. We know that is the capillary pressure at the venous end about 12, at the mid capillary pressure 20, and at the arterial end, which is our interest, is 32. So any pressure over this pressure will lead to the slowing of the blood circulation, accumulation of the platelets and coagulation factors, and formation of the thrombus, and lead to the ischemia and the vicious circle of changes. What happened? Lead to the disrupted blood supply, deprived tissue of oxygenation and nutrients. As this pressure lead to the pressure on the vessels, shear will to the angulation of the vessels, and the friction between two objects, like that. It's a common site. In every position for the patients, we have the common sites according to the pressure intensity. We have in prone position, in supine position, in lateral position, as we said. But can we imagine if the patient in hospital develop pressure, as we said before, more than 32 pressure. It's from 40 to 60 over under the sacrum, and maybe 70 to 95 millimeter mercury over the greater trochanter. Also, in sitting position, we have a different levels. Yeah, we have a different size, sorry. Also, the pressure under the ischial tuberosity may reach to the 300 millimeter mercury and may reach 700 millimeter mercury over the hard object. What's our plan? Here we have a risk factors. What is the risk factors and why? From this, as we said before, we have these risk factors: limited mobility, and incontinence, poor circulations, poor health and education. All of this means what? This more common in age over 65, diabetes, peripheral arterial disease, immune deficiency, steroid therapy, smoking, dementia, malnutrition, sensory deficit, and circulatory disturbance. So, must be the patient assessed within the first 6 hours of admissions. We have two scales for the assessment of the patient: Braden scales and Braden Q scales. As Braden scales have 6 categories, every category take a number from 1 to 4, except the last one, friction and shear, give him 3. So the score from 60 to 32 points. The lower the score, the greater the risk to the skin breakdown. As we said, at risk from 15 to 18, moderate risk 13 to 14, high risk 10 to 12, and very high risk less than 9. Also, there is a more usable one is the Braden Q scale, especially in the pediatric. They add a tissue perfusion and oxygenation, and they give each category 1. So give him the score ranging from 7 to 28 Lower score indicate higher risk. As we said, low risk from 22 to 28, moderate risk from 17 to 21, and very high risk from less than 16. Okay, now how to prevent? These slides can summarize what's the prevention. So we must take care with this patient by proper nutrition and hydration, make sure pressure is off, avoid complete immobilization, manage skin moistures, and ease pressure and prevent frictions. Now the patients come and he has an ulcer or injury. What we can do? So we can assess and document about the cause, the site location, the dimension, stage or grade, necrosis or slough, exudate amount and type, local signs of infection, pain, wound appearance, surround skin, undermining, tracking, sinus, whatever, fistula, and its odor. Type. Based on this visualized, we can classify the injury in partial sickness, stage 1 or 2, and now the advisory panel changes the Latin words, this into Arabic one, by take this shape of the number. Full sickness, pressure ulcer 3 and 4. Also, we have unstageable pressure ulcer and suspected deep tissue injury. As we see from this table, we can see stage 1, the non-blanchable erythema, may be warm or painful like that. Stage 2, partial sickness skin, بيبقى erosion or serum filled blisters like that. Stage 3, deep, till subcutaneous tissue, but don't touch the fascia. If it passes the fascia or touches the fascia, it's now deep, up to the bone. Also, we have all of this may lead to the bacterial invasion and osteomyelitis. We have also deep unknown ulcer, as there is some eschars, slough, and they hide what's behind. Also, we have a kidney terminal ulcer, which is, but the precedes the death. As this time, the first stage D is very difficult in plaque 1, because you will find the skin around is warm and that. And this is the shape of the different stages of the injury. How? Now, going to our journey, we change or move to manage. We have a different modalities in treatment of or alleviate these conditions. Support surface, which is very important, from air mattress, whatever, pillow, and the repositioning and the rotational support to prevent the ulcer development. From this reposition, now it's by advisory panel defined that it's pressure more than 90 minutes will start the injury. So our habits, we always advise the patient, advise every 2 hours. No, must be repositioning every 1 hour. And we are going, and we have repositioning, nutritional support, and now we move to the debridement and local wound application to prevent contamination and the promotion of tissue healing. Adjuvant therapy, as Professor Pasetto said about physical therapy, and surgical repair. This is the treatment intervention about air fluidizing bed and with lower aid beds and so on. What can we do with this patient? Must take adequate fluid, increase calories intake, increase protein intake, especially microelements, zinc, iron, vitamin A, C, and E. This is the physical therapy, which is very important. Just again, a new knowledge from my Professor Pasetto about the fluorescent light I haven't before. And this is the low-level laser therapy. What they play? It's play a role that they reduce inflammation, anti-edematous, improve circulation with stimulation, immune response, and increase granulation tissue. And this is very
some cases treated by this type of laser therapy only. Whirlpool therapy. This is a mechanical debridement used in especially infected, heavily draining wound. As this. Also, the magnetic therapy play a role as will be increase reepithelialization and promote healing. Neuromuscular electrotherapy also stimulates cell to improve blood flow and enhance the growth of different cell types in each phase of plague. So our rules today, we always request the physiotherapist to see our pressure engine. What's the dressing? All of us know these slides. The ideal dressing must be remove exudate, moisture control, allow gas transmissions, and prevent infections, biocompatible, biodegradable, non-toxic, cost-effective. All of these is ideal dressing. These some types of dressing: foam dressing, gauze dressing, alginate dressing, transparent membrane, composite, hydrocolloids, hydrogel. All of these dressing play a role, but must we choose the best one for each case. Now we go to surgical intervention. Surgical consultation in just cases. Advanced cellulitis or suspected source of sepsis, undermining tiny sinus tract septum, and not response to conservative debridement. Also, stage 3-4 not respond to conservative treatment. So the first step in our work is the debridement. Sharp or surgical debridement is the best one. Mechanical, non-selective debridement as well, pour, irrigation, widget, all this, enzymatic debridement, autolytic debridement. Excision. When we decide we'll excise, we must be fully excise the pressure injury, abnormal skin granulation, necrotic tissue, persa involved, even the bone. Flap. We must convince that the only surgical covering is the flap, not other. So the flap must be with good quality blood supply, composite tissue, as large as possible, minimize manipulation around the tissue, must locate suture line away from the pressure area, minimize tension, closure without any tension. It's okay. I have 5 minutes, please. Post-operative, we regularly monitor the wound, especially support surface بالذات. Once you finish your operation, must give your information about this position and the transfer. And also, we gave him progressive setting protocol and how to manage with the new position. We have some surgical cases. This is like one. This is the third category, not fourth stage one. This third stage, because I can't find the third. So, but we have a tunnel, we have a sinus, but this is third stage. Before this, an old case of one, we move this rhomboid and we cover it. Now, after the era of freestyle flap, all of us have our special Doppler and locate the perforator one and move the flap according to this perforator. And from here, I congratulate Magdi Abdel Muqtadir. He is fine in the setting. He is a pioneer of this freestyle flap. Thank you, Dr. Magdi, for your information that I gained from you. Yeah. Now I can move because I have the perforator and I can do everything without anything. Also, sorry, I decide the perforators and I can move as I can, like that. This is a very difficult case because it must be to assess the anal opening before. Okay. Okay. pressure ulcer have major impact on the health state, quality of life, health and care costs. Treatment of pressure ulcer is critical to promote healing. Effective of treatment of strategies for improved health outcome include complete wound healing, reduce healing time, reduce wound surface area, pain, prevention of serious complication of infection. And thank you so much.
Thank you, Dr. Aaf. Now we'll move to the next speaker online, Professor Magdi Nabil. He is a Major General also, but he can't come because he has a COVID. ونسأل له السلامة يعني. Professor Magdi Nabil, he will speak about aesthetic restoration of nail bed after trauma and glomus tumor excision. Professor Magdi, hello, how are you?
Hello, good morning, everybody.
We missed you too much, Magdi.
Thank you very much.
Can you start, Magdi? Thank you so much.
Can I start now?
Yeah, can you start, Magdi?
Are you sharing my screen? This meeting for the second time, but it's this time is virtual. Anyway, because of COVID-19. Okay, our presentation today about aesthetic restoration of the nail bed after nail bed injuries and glomus tumor excision. Did you see my screen now? Huh? Okay, huh? Our fingertip injuries is mentioned in our Holy Quran 1400 years ago. This is a very particular part. Our God swear by this particular area in the body, the human body. Actually, this area carry our personal code, unique personal code. By this code, everyone has its identification. It has a very peculiar vascular supply and nerve supply. Also, the sensory cortical representation of each fingertip in the brain has its chair, that every finger sitting on this chair. And in our life, this area has a very aesthetic function, especially for women. However, on the other side, on the bad side, on the injuries, this carry a major dysfunctional disability of this particular part in our hands. Affect our function that maintain our daily life activities and the hobbies. This area has three main components: the nail bed area, the distal phalanx, and the bulb area. As we see in this photograph. Evans in 2000 classified these three main components into different grades of injuries, as we see in this table. Allen classification, according to the level of the amputation of this particular part, we have a 4 types of fingertip amputation injuries. This is a different type of fractures that could occur or happen in the distal phalanx, and the level of amputation, it is transversely oriented or volar or dorsal oriented, as we can see in these photographs. The nail growth occur in a 0.1 millimeter a day. So to achieve a full recovery of the nail after treatment from injuries, we need 5 to 6 months to achieve a full growth and full aesthetic looking of the nail bed area, from 70 to 160 days. We have different treatment options, starting from the conservative measures and multiple dressings, primary closure, using a skin graft, full thickness or split thickness skin graft, local flaps, VY, or cross finger flaps, or neurovascular or palmar flaps, or even using microsurgical skills to have a free flap for coverage of any defects. And all of these depending on the age and sex, the job, and the level of the amputation. Starting by nail bed injuries, as we see in this photograph, crushing avulsion injury, after primary repair and 1 year later after recovery and achieving a full aesthetic recovery of the nail bed area. Another patient with a very tough fracture in the distal part of the phalanx and 1 year later after full recovery. Another case, and 8 months later after recovery. 2 years later, after complete achievement of aesthetic, nice looking of the nail bed area. Crushing injury with comminuted fracture of the distal phalanx, just repair of the soft tissue will allow all these small fragments without any using of any type of fixation. These bone fractures or bone fragments will coalesce and fuse with each other. And this is after 8 months of recovery. If you have a sizable bone fragments, you can fix it by a small K-wire, and you will have a good union later with good aesthetic looking of the nail bed area. If you have 3 fragments, like this case, also fixed by small K-wire. When we have a defect in the nail bed area, we can achieve a split nail matrix graft from the toe of the foot and recover or resurface of this area, and you will achieve a fully good recovery of the nail bed area. Or even a complete graft, but actually in those cases, you will not have any recovery of the nail bed area because the nail bed matrix and will be destroyed. Complete avulsion with exposing of the terminal part of the distal phalanx. Recovery 8 months later. Crushing injuries 8 months later after recovery. In oblique amputation, as we see in this case, palmar flap could achieve recovery and restore the function of the fingertip. Dorsal oriented amputation, VY recovery can restore of this particular part of the fingertip, as we see in this case, 6 months later. Bulb area defect, full thickness from the hypociner area, and 8 months later after complete recovery and the integration of the full thickness skin graft to the pulp area of the hand. Cross finger flap from the index to the thumb. You can achieve the 2-point grip. This is a 2 months later after recovery with donor site accepted results. Exposed bone, cross finger flap from the middle finger to the index. This is the 8 months later after recovery. With good 2-point and 3-point grip. We can see the full function, full flexion and extension of the distal phalanx with good coverage of the exposed bone. Another patient with exposed bone, oblique volar amputation, cross finger from the middle to the index, and 2 years later after recovery. By using a microsurgical skill, we can reimplant the very distal part of the amputated digit, or using the microsurgical skill also for the toe-to-hand transfer in restoring the normal length of the fingers, as we see in this case. With super microsurgery skills, we can reimplant a very distal amputation of the fingertip. Moberg flap in restoration of the thumb, which is the most important thumb of the hand, representing 50% of the hand function. As you can see, the patient can restore his writing function using the 3-point grip, holding a pen, and can write again. The prosthesis, finger prosthesis, also one of the methods that you can restore the aesthetic looking of the hand, especially in women. As you see in this crushing injury of the thumb, you can see in this video presentation, by using a prosthesis to camouflage the amputated part of the thumb, so the patient can do all the function. And you see here, so aesthetic and functional outcome will be restored in those patients. Regarding the glomus tumor, which is one of the commonest tumor affecting the female between 30 to 50-year-old, and with classic triad, pain, point tenderness, and temperature sensitivity. The glomus tumor could be present under the nail bed or in the bulb area, as we see in this photograph. And the diagnosis depending on the high index of suspicion. Suspicion is very important to achieve this diagnosis from history and clinical examination. In some advanced cases, we can see the, as we see in this case, the bluish discoloration under the nail bed, the distortion of the nail bed, or even in some cases in plain X-ray, we can see distortion of the distal phalanx of the fingers. MRI is one of the very accurate measures to localize the tumor, as we see in those pictures. In our surgical approach, we can approach this tumor through dorsal or volar or lateral approach to achieve the tumor according to the site of this tumor in the finger, whatever the under nail bed or in the bulb area. Through dorsal approach, we remove the nail plate blunt dissection and approach the nail bed area. Doing the excision, as you can see, this is a tumor. By using the microsurgical magnification, we can remove a very small tumor, as you see in this case. This is another one. We can see the bluish discoloration under the nail bed in comparison to the other finger. This is the MRI to localize the site of the tumor. This is an intraoperative view after actually removing the nail plate, incising the nail bed area, removing the tumor, and send for histopathological examination to confirm our diagnosis. This is after closure and resetting the nail plate. And this is 4 weeks and 5 months later after complete recovery. This is another patient. You can see the bluish discoloration under. This is confirmed by the MRI. This is an intraoperative, and this is a tumor. This is after closure, resetting the nail plate 3 weeks and 6 months later after complete recovery of the new nail plate and achieving a good aesthetic result of this area. And this is the histopathology. Through volar approach.
Professor Magdi, your time, please.
2 minutes more. And this is another case.
Already
you
take. Sorry.
Okay. This is a lateral approach. Big toe also, we can find some cases like this. The deformity in the nail bed we can encounter in the clinical practice: splitting of the nail, non-adherence, cornified, pincer deformity, hooking, spikes, and cysts, as we see in those deformities. splitting of the nail and correction by surgical correction, pincer deformity, especially seen in the female. So in conclusion, the ultimate goal of fingertip reconstructive procedure is to obtain functional and aesthetic outcome. The functional evaluation involved objectively and subjective criteria, including the motion and the 2-point discrimination, the complaint of hypothesia, cold intolerance, time required to achieve a full healing and repair. The importance of meticulous and the immediate repair of the nail bed injuries cannot be overstated. The results of primary repair far exceeds those of the secondary reconstructive attempt. The severity and the nature of the inciting trauma play a significant role in the functional and aesthetic outcome. Thank you very much to be here, and I hope everyone is enjoyed by my presentation. Thank you, Dr. Professor Atif, and thank you for the
Thank
host
you,
and,
Professor Magdi, for your presentation and for your result and for using the technology well. Thank you, Magdi. You are one of the pioneers in this field. Thank you so much.
Thank you very much.
Now we move to the next speaker, one of our friend, Professor Mustafa Al-Masri. Professor Mustafa is a professor in Suez Canal University, but now he is working in Sweden. He will speak about cell-based skin grafting. Professor Mustafa.
Thank you very much for this. Oh, sure. Yeah. Sorry. Thank you very much for this invitation and this quick fix with the presentation. As Professor Atif has told, my name is Mustafa Al-Masri. I'm a plastic surgeon. I'm working currently in Sweden in Linköping University Hospital. And I'm going today to talk about the treatment of chronic wounds with cell-based skin grafting. Our burn center in Linköping is one of the 2 national burn centers in Sweden. It serves the southern part of Sweden, and it receives also patients from the north of Sweden. We treat about 100 adults and about 200 children per year, and it's about a team of 89 co-workers and 12 plastic surgeons. We have been using autologous cell therapy for burns and chronic wounds. That was for 15 years ago. But the success with this treatment was quite variable, actually. So for the last 4 years, we have started our new research and development unit for skin and cultured cells. And the main mission for this is to have a simple and safe skin regenerative solution for burn victims and chronic wound patients. As we all know, the regulations for the cell-based therapies in Europe has been changing a lot, and it's extremely difficult nowadays to treat patients with their own cells as compared for 10 years ago. It's a big difference in the laws, and it requires a huge investment if we are going to really treat the patients in the same way we were used to treat them before. And that's why we have this aim to promote the natural healing, to find a regenerative solution for the skin wounds, and to detect mainly early markers for complications. And how we are trying to really avoid the problems with all the administrative part and the huge investment to start a big regenerative lab to provide these solutions for the patient is to find a cheap bedside regenerative solution that is efficient and safe and clinically acceptable as well. And here is part of our team. It's me, it's my colleague Matilda Carlson, which is the research nurse in our, and my colleague Ahmed Al-Sarfi also, who is a cell biologist. And this is a small picture about how we do it actually in the operation room, the whole procedure. And the procedure here starts with harvesting a small biopsy under local anesthesia. It's a split thickness skin graft. The biopsy is processed inside the OR under laminar airflow. The autologous keratinocytes are isolated. Parallelly with that, the wound bed is prepared. We had a big problem with those cell-based therapies because these therapies are fluid-based therapy. So you have cells that are actually suspended in a fluid. And when you put them on wounds, it's extremely difficult to know how I'm putting them, where I'm putting them. It's extremely complicated. So we have been testing different concepts how to preserve the fluid on the wound. And this is by this way, doing a chamber to inject the cells inside the chamber. The whole procedure takes about 2 hours, starting from the skin biopsy until application of the final treatment, actually. I will give some fast, rapid examples about the patients. Here is the first patient. This was a meningomyelocele patient with a bed sore in the right knee. We have been trying almost everything with her. We have been doing first the classical wound care, debridement, skin grafting, and even a muscle flap, and nothing has worked. So we had her for 979 days in our center for treating this ulcer. And this patient was the first one to be included in our study, and she was treated with cell-based skin grafting bedside. And you can see the progress of the wound until day 68 with good progression, actually. So in the graph below, you see that the size of the wound have been just going down in 64 days. Another example is a patient also with a chronic leg wound after a free fibula. Those wounds are quite resistant, especially in the light aspect of the lower leg. 117 days with the open wound after debridement and classical wound care, and then treated with the cell-based therapy, quite healed in 63 days, actually. Another couple of patients, 419 days with a chronic wound, ischemic wound, actually, quite healed. The picture at the right is after 175 days. Another patient also diabetic foot wound, treated in almost 21 days, almost full healed. This is a gunshot, actually, and this patient was treated actually twice with cells. This is the first time the wound, it was improving, but then it became stationary after 68 days. So we did a newer application, and the patient is actually visiting our clinic 2 times a week now for dressing changes, and it's progressing quite good. And in the graph you see it was stationary for some time, but now it's getting better after the second treatment. One of the patients also who had a chronic wound in the scalp for 120 days after radiotherapy, and those patients are actually very resistant for the normal skin grafting, but actually with cells it's progressing very well. Now we have 21 days measurements, and we are still following the patient, doing good as well. All these procedures were done with local anesthesia and bedside, actually, without sending the skin biopsy anywhere or something. This is also chronic leg wounds, venous insufficiency, and in 18 days, almost full healing after the same procedure. Same also, chronic wound, 92 days. It took some time, but it was healed. And you see the progress of the wound in the graph. So this is like almost all the patients that we're testing the treatment on them, and all of them are showing a trend of reduction of the size of the wound, but on different time scales, actually. So it differs between different patients, but all the patients selected in this study were very difficult wounds to heal, so they were not like straightforward patients at all. So I'm happy at least we have achieved this result with them. This is as well a burn patient, and mainly this treatment, the cell-based skin grafting, was developed for burn patients with major burns. And this is a major burn that we had on our burn center for about a year ago. And the patient was burned about 85% full thickness burns. And after multiple applications of different techniques of wide split thickness skin graft, meek mesh, as you can see in some of the parts, we had some left wounds in the back, in the gluteal region and in the lower end of the back, which was very resistant to heal. So we treated different regions with different combinations. So the upper wound at the upper side was treated with wide meshed skin grafts and cells. The lower wounds where you see the chamber is constructed, that was treated with only cells. and the wound to down was treated only with the skin grafts. And this procedure was done bedside, and this is like how it looked after day 6 and day 10. The thing which is almost amazing is that the epithelialization for wide meshed skin grafts plus cells is quite known to be quite fast, and it is very, like, it shows here. Day 6 already it's epithelializing, and at day 10 it's almost like perfect. But the regions treated with the cells as well, only the cells are quite healing quite nicely actually. The interesting part is that the areas which are only skin grafted are not the best, but this is maybe expected. And this is like day 46 at the follow-up after discharge. It's almost healed. So, thanks a lot.
Thank you so much, Mustafa, for your good idea. Now I think we have time to discuss, but give me the chance to thank all the participants in this session, especially my teacher and my professor. And the best one that he learned me, Professor Muhammad Adri. Thank you, Professor Muhammad Adri, for attending. He's the honorary president of our society, and he did a lot and will do a lot for every plastic surgeon in Egypt. Thank you, Professor Adri, for what you did and what you do for us. Thank you for organizing committee. Thank you, Marwan, for this session, gives the chance to participate in this conference for this session. Thank you for all. Now we are going to the lunch break. Thank you.
Thank you so much, ladies and gentlemen. Now it's our favorite time of the day. Please proceed for the lunch. Thank you. Check, check. Check, check. Okay. Just try to show the gist of audience also.
No, 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 no. But I already have his lecture. He must be there. I already have his lecture.
Check, check. Good afternoon to everyone once again. I hope we enjoyed our lunch, didn't we? I said it was the favorite time of our day. I was right. I believe lunch breaks are given so that we can work out. Am I right? So that lazy people like me can stay fit and do workouts. All right, ladies and gentlemen, may I now please call upon Dr. Mohammad Al Harbi and address the gathering.
Hello, assalamu alaikum. Good afternoon, everybody. We'll start our session today. My name is Dr. Mohammad Al Harbi, consultant plastic surgery, head service in King Abdullah Medical City in Mecca. It's my pleasure to join this great conference. I'd like to thank the committees for this opportunity. So we'll start our session today about advances in burn reconstruction. Would like to welcome Dr. Eduardo Gus for his topic. Dr. Tpazo, he is assistant professor of University of Toronto, and pediatric department, pediatric plastic sick kid hospital, and his specialty about pediatric plastic surgery. Welcome, Dr. Eduardo.
Okay. Thank you for the introduction, and thank you for the meeting committee for inviting me for this talk. So I'm going to be talking about BTM. BTM is a product that is not available in most countries as of now. It's not available where I practice, which is Canada. But before my appointment in Canada, I had an appointment in Melbourne, in Australia. And this is where I got really experienced with BTM. I have nothing to disclose. I do not work for the company. The opinions that you're going to hear are based on my clinical experience. So the product that I usually compare it to is Integra, which is the dermal substitute that I was really experienced with, and that most of you are experienced as well. BTM, the big difference is that it's made of biodegradable polyurethane, which is 100% synthetic. And because of that, it's very, very resistant to bacteria. So it gets heavily colonized, and that's not a problem, as opposed to Integra, which is pretty much biologic, and we lose it very easily
for infection. It also has an outer layer, an outer membrane, that once the granulation tissue ingrows into the foam, you're able to peel it off, and it's a perfectly fine graftable bed. So pictures here are not doing a lot of justice. This is 9 weeks post-application, and hopefully the video will work. So you can appreciate that because the outer membrane is transparent, you can actually see that the tissue is blanching. And as you peel it off, it leaves you with a perfectly smooth layer of granulation tissue, which makes the grafts very much stable. This is the type of result that you get immediately post-operative. This is dressing takedown on day 3, so you can see how sturdy and well adhered and integrated the grafts are. And this is 4 months post-grafting. The one thing that I really find very interesting about BTM is the fact that you can keep the outer membrane, in theory, indefinitely. So those of you who have experience with Integra know that usually by the 3rd week, when Integra is ready to be grafted, it starts to auto-delaminate. It peels off spontaneously, and you have no choice but to graft that wound bed. This doesn't happen with this product. The membrane stays, and later on today or tomorrow, Dr. Fish, who also works at SickKids with me, will show you a case where he left BTM for 3 months. And basically, this wound shows this inferior aspect of the wound has had a BTM applied 5 weeks prior to this picture. And the history of this patient is that she tried to commit suicide, and she had very deep burns to the anterior torso. So basically, we excised everything. We applied BTM to the entire torso. And unfortunately, the upper part, the chest and the breasts got infected, which does happen every now and then. And we had to remove it because it really created a layer of pus underneath the product. So we removed it, we re-allografted the upper torso, and then a week later, we reapplied BTM. So you can see the difference of the product. In the inferior aspect is that solid appearance of a granulation tissue that's a good graftable bed, as opposed to the superior aspect, which shows the foam with all the air-filled bubbles because it's not mature, it's not ready to be delaminated. This is another case, so I can illustrate these advantages over Integra. Basically, this patient had a hematoma, and obviously with most dermal matrices, if you have a hematoma, there's nothing you can do about it. You have to remove, open a new product, and spend the money again, which doesn't happen with this foam. So this foam is actually washable. You remove the staples, you wash it out, wash the hematoma, make sure the bleeder is identified, and you can re-staple it back without having to open another package. That's exactly what we do to areas like this, which are not integrating as well as other areas. To be completely fair and honest, one of the things that Novosorb, which is the company that manufactures this product, advocates is that BTM prevents scar contracture, and that's something that I completely disagree with. So this is also another patient that had a pretty deep burn to the anterior torso and neck. As you can appreciate, the inferior aspect of it was grafted right after allografting, and we applied BTM to make sure that there were no scar contractures to the upper torso and neck. And on the lamination, you can already see that the patient did develop an anterior axillary line scar contracture.
So at the time of grafting, I already released this thick band of scar. So it's not a perfect product, but it does have advantages over the other dermal matrices. And this is the result upon graft takedown. I apologize, these first sets of pictures are not great. This is another case that shows how this product indeed creates scar contractures. This lady was heavily intoxicated with alcohol, fell face first onto a bonfire. She was brought to our ICU. We had to excise pretty much the full face, anterior aspect of the neck as well. This is the allograft before we remove it. And hopefully you'll be able to appreciate that this wound basically is a 4th-degree wound. The fat of the face was also burnt, and the wound bed was exposing most of the facial muscles. So what we used BTM, this was the first case actually in Melbourne in Australia that BTM was applied to a face. We applied to the entire area except the eyelids, because we wanted to use full thickness grafts, avoiding ectropiums. So this is pretty much on the 2nd week, right after application of BTM. This is exactly how the product looks. It starts to be populated by blood, which is desirable because you want the growth factors to be within the foam. And 6 weeks later, this is how it looked. So very mature and ready to be delaminated and grafted. And that's the immediate post-op result. So we were very pleased at this point. But 3 weeks post-grafting, she was already showing bilateral ectropium. 6 weeks later, she had microstomia and was unable to eat. So we did bilateral commissuroplasties. 10 weeks later, she had a neck contracture. And this is the graft takedown from the neck release, but you can also appreciate that the nostrils are starting to be problematic. So unfortunately, I can't tell you that BTM won't prevent scar contractures, but I can tell you that it can be used to treat scar contractures. And this is a case, a 10-year-old from the Mennonite community in Canada who sustained this 15% flame burn to pretty much the entire left upper extremity, the torso. They did not seek medical attention. And he was treated for 10 months just with ointments. And obviously he developed this very, very severe form of contracture. I can't even call this an axillary contracture because really the arm is fused to the chest wall. So this is upon presentation in our hospital. So we started the releases. We did the major aspect of it first. We allografted that area and started mobilizing the shoulder because range of motion was our top priority. And then we made the releases to the wrist and to the arm, and you may be able to appreciate the thickness of the scar that this kid developed. It was a pretty dramatic case, and honestly, having operated in Canada, Brazil, Australia, and in Angola, I've never seen such a severe case. So all of these areas were allografted, and once we were happy with the wound beds and he would be, in theory, ready to be grafted, then our concern was the fact that he would require a lot of skin. And by harvesting his entire back and one of his thighs, or maybe even both of his thighs, rehab-wise, he would go backwards and he would stop mobilizing again, and he would lose all the gain in range of motion that he was having. So we decided to use BTM. And again, BTM is not approved in Canada
but we can get it through a special access scheme. So this is what we did. We applied BTM to the entire area because it allows us to mobilize the patient. And I think this is by far the most incredible aspect about this product, is that, again, it takes 6 weeks for full integration to be ready to be grafted. You can wait longer if you need to, but this allowed our therapists to really go to town and get this kid mobilizing and reestablish his range of motion. So this is the area upon graft dressing takedown. Rarely do we mesh the graft in kids, and I'm going to be talking about this a little bit more in my next presentation. We did mesh graft the torso just to minimize to a degree the area that we needed to harvest, and we did sheet grafting to the entire upper extremity, and that's the result 6 months later. So you will appreciate that there is a contracture now, an axillary contracture on the anterior axillary line, which will need to be fixed, and it has been causing issues. But most of us have had pretty dramatic cases, and I do consider this a pretty good result. So the indications or advantages that I agree with the manufacturer is when you have lack of donor sites or scarce donor sites, it's better than the other dermal matrices because it does not auto-delaminate. So if you need to wait for the donor sites to heal, reharvest them, heal again, and reharvest them again, it will be stable. It's great for wounds that are extremely deep, so you can add an extra tissue of an extra layer of tissue. Obviously good when the deep structures are also exposed. But most importantly, in my opinion, is that it tolerates mobilization. You can rehab the patients before they are grafted and after they're grafted again. And I disagree profoundly that it prevents scar contracture for the reasons that I just discussed with you guys. Thank you.
Thank you so much, Dr. Eduardo, for this nice presentation. Difficult cases. You know, the burn cases always have a big problem with the scar contraction. I think we'll keep the question at the end of the sessions, if it's okay. So I'd like to call Dr. Ziad Al-Harbi. Dr. Ziad, he is consultant and assistant professor of plastic and reconstructive surgery department, Fakih Care and Fakih College of Medicine in Jeddah, Kingdom, Saudi Arabia, Secretary General Saudi Association of Plastic Surgery and Burn of Saudi Arabia. Been work with my colleague Dr. Ziad Al-Harbi in this field, and I do believe he is a lot of things to present for us, promising. He will talk about the nanofat and PRP microneedling for post-burn facial and body scars. Welcome, Dr.
Thank you very much, Dr. Mohammed. Thank you, Dr. Marwan and Dr. Mohammed Al-Qahtani for the invitation to such a wonderful conference. As always, burns and wounds are very important issues in plastic surgery. I will be honored to speak about nanofat and PRP transfer in scars after burns and after trauma. I have no disclosure. When we treat scars, we should define scars or classify them either to acute one or chronic ones. And normally in our practice, we receive very old scars after burns, maybe after 10 years or 20 or maybe 30 years. So one of the technology that we do use for treating them is the application of nanofat technology or the platelet-rich plasma, as you have heard or maybe seen in the literature, including the PubMed papers. But speaking about nanofat, it is indicated through many steps. First of all, the harvesting, then the processing, and then the lipoaspirate product, and then to the injection step. When we speak about harvesting, it must be through very established procedures. It began actually with the macro cannulas, ranging to the micro cannulas, so either as developed by Guy Magalon in France or previously by Sidney Coleman in New York. But when we speak also about liposuction, we should define it either manual liposuction or machine-assisted liposuction. For such technology, we like to use simple syringes with manual aspiration rather than using a machine for it because we need to process the fat. So we have done a study in Germany. I was honored to be one of the group to investigate whether smaller cannulas or big cannula make a difference for your cells that you are going to inject later on. And interestingly, we have found that smaller cannulas, the more smaller size you use for your harvesting, the more viability of the adipose-derived stem cells you get when you inject. While on the other hand, if you use bigger cannulas, you will get, of course, more vascular endothelial growth factors, which you need for the vascular supply in your product. And also we have done a further analysis toward whether these cells are really segmenting inside the tissues and they go in the basement of the tissue to form a adipose layer again, because this is what you want to treat for the scars. And we have found that our cells are invading with time without any problem. So then you go to the process of the fat itself, and the processing, we stick to a protocol of the Sidney Coleman, but as also modified by Tournard. So we do the centrifugation process 2 times rather than only doing it in 1 time. After the emulsification process and after the nanofilter that I'm going to show later on in the slides. So what is inside the fat? Inside the fat, you have the mature big adipocytes, and of course, they are representing the bulk of the tissue, and you have also the blood cells, you have the stromal vascular endothelial fraction, which is including the adipose-derived stem cells ranging from 3 to 7% of the whole products. As you know, these kind of mesenchymal stem cells can go to adipogenic lineage, but also they can do another lineage, making the bones, making the tendons, making also the muscles. But we are interested right now to go into adipogenic lineage again from the beginning. We have done also a study that we have published in the PRS toward specifically the use of antiseptics inside the OR, whether they are killing our cells or not. And of course, we have found that, for example, the beta-isodonor or the betadine product is very toxic for our cells. Also, the acetic acid products are very toxic for our cells, while for the other hand, for example, the polyhexanide products are safer. Anyway, we are speaking about matrices. We have seen a very nice lecture previously by Dr. Eduardo regarding the use of very different regenerative templates, while you can also combine such a procedure also with the dermal regenerative templates, for example, Matriderm, Integra, or other products. Like, for example, in this child, we have done the regenerative template application, and this is the picture of this child after 20 years when he is young right now. So what happened right now in the tissue, if you investigate Matriderm and the nanofat technology together, when you inject them and transfer it into the tissue, you see the red color is the collagen product of the regenerative template, and the green color is the adipose cells, and the blue color is the nucleus of these adipose cells after 14 days of application. So right now we will go to the clinical cases and the clinical scenarios that we have done in our centers. We have do it with nanofat and microfat, and I will explain clearly what is the difference between microfat and nanofat, because normally we combine them also together in many cases. Nanofat, as you see in the picture, mostly is injected in the very superficial layer of the skin. Microfat mostly injected in the reticular dermis or in the dermal layer, while macrofat is injected in the very deep layer, namely the adipose tissue. So if you would like to do gluteal enhancement or breast enhancement, clearly you would use macrofat. If you would like to make lip augmentation or facial augmentation, you will go to microfat. If you do rejuvenation or regeneration to treat the skin, you will go to nanofat. Well, you have to process the cell toward microfat first, and then you go to the nanofat step. This is the clear difference between microfat in the middle and the purified, qualified, very powerful fat cells on the right side, namely the nanofat. Nanofat is used for scars more than microfat because you like to treat the scars rather than fill under the scar. But if you would like to make detachment first by percutaneous release, you can do the filling with the microfat first, and then you rejuvenate the whole tissue of the scar with the nanofat technology. And this is a study that we have done in the British Journal for such results. Remember, nanofat doesn't lose the stem cell ability rather than having actual more powerful ability, because the stress keep your cells alive during the process, as described by Gimbel in Nature publication. So nanofat has no filling capacity if compared to microfat and macrofat. It increased the dermal thickness, and it make improvement in the dermal architecture by transplantation of the autologous stromal vascular fractions as described in many studies. If you look into the literature, you see a lot of aging skin publications, scars publications, wound publications by such technology. In our practice, we use nanofat for scar rejuvenation, for post-burn and wounds, for anti-aging rejuvenation, for facial cosmetics, and for hand cosmetics. We also like to combine it with platelet-rich plasma. We use platelet-rich plasma for wounds. This is a diabetic patient, type 1, blind, very complicated, collateral blood supply in the foot, no any option for free flaps. We injected the platelet-rich plasma 3 times on this foot, and we could able to save the foot. And you can appreciate also the surrounding skin, which has been regenerating very well on such patient. So therefore, when we use fat, we like to combine it also with platelet-rich plasma. Very simple set, no machine, manual aspiration, processing, and then injection. You have very micro cannulas, because micro cannulas are better than macro cannulas in terms of adipose-derived stem cells viability. And after that, we do the aspiration. I like it from the abdomen. I like to use the centrifuge, as you see in this video. When you take out your syringe, you will appreciate the separation of the blood and the oil, and you will have only in the middle, you can see that you have only 3 to 4 cc out of 10 cc very well purified fat. But this is still microfat, this is not nanofat. So after we separate it, we make the emulsification process, as you see. This is clearly described by Patrick Tonard and Gent in 2014, but still, this is emulsified microfat, and this is not nanofat. So we are not yet there. So what we do is that we use a filter, and through this filter, you go only 1 time from the right to the left, and you can appreciate the difference. On the right side, it is juicy, it is completely filtered, the emulsified product, and on the left side, it stays with the collagen product. And therefore, this product on the right side, right now, the nanofat, you can inject it in a very superficial layer because it is more liquid in nature. So again, this is the picture of the steps that you reach until you go to the right side. And it is described also in many studies that when you use nanofat, you can combine it with PRP. The question is whether you use it in the same day or after 2 weeks or after 4 weeks. This is also another area of studies. We like to use also microneedles because we believe that microneedles make good collagen induction to the scars. And then we are making right now an observational analysis to our patient after we treat them with such technology. We like also to do microfatting, filling to enhance also the volume depression that result also with the scar as you see in such cases. But the most interesting thing is that you can transfer not only the platelet-rich plasma, but also the nanofat through not the needles, but through the microneedles, and it go through them because they are very small particles. So when you treat scars, you can make extensive microneedlings, and you can transfer while you are doing the microneedlings through the ampoules, either the PRP product or the nanofat product as described in many publications. This is a young lady from Medina who came to me into practice and before 1 year, and she is continuously following up for the treatment of the scar. And right now, until now, we are not yet with the final result, but this is an update about her. This is also a soldier from the southern border of Saudi Arabia. We have started the application of the whole concept, left side before and right side after. This is a teacher who we have done for her nanofat application, microneedling, and of course also PRP injection, left side before and right side after. And you can also see that we have done some augmentation to the lateral area of the scar. This is also another patient in which that we could see some improvement of the scar. We have also augmented a lot of fat, but the fat sometimes resorb, so it need also sometimes another sessions. This is also another patient who came before, I think 4 months now, 4 or 5 months. She is a teacher, and she got scars with black discoloration, and especially the most ugly part for her was the nose. Although for me, the most ugly part was the whole left face, to be honest. So we have consulted her to do a resurfacing through microneedling, nanofat injection, also augmentation in some area of the left side, but later on with fractional CO2 laser to have better result and much bigger enhancement, as you see on the left side, in the lateral side. Also here, you see on the right side, right now, currently the update of her, but she will continue also with us the treatment. This is also another patient that got a sort of transposition flap in the face because of a tumor surgery. The scar was a little bit not satisfying for her because it was deeper. So we could detach the scar first. You can apply fat, you make volume, and then you treat the scar from the outsider surface through microneedling technology and nanofatting, as well as PRP injection after every 4 to 6 weeks in the clinics, no need for surgery. Right now, we are making also another cohort for our patients. We are treating scars in the hand, aging process in the hand through nanofat applications and PRP also injections to see the difference between before and after. And we could see the appreciation of the patients when we do such transfer. So in conclusion, reconstructive surgery or regenerative surgery in the science of plastic surgery are all established. But the question is, we as plastic surgeons or cosmetic professionals, we have to give the patient the right indication. Sometimes it works with reconstructive options, with grafting options, with regenerative templates, with flappings, and sometimes it works with new technologies. It is depending on the evidence, on the defect itself, and on the experience of the surgeons, but it is never an ending story. We should exchange ideas, and we ask, of course, people around us to reach the best optimal result for our patients. Thank you very much for attention. Shukran.
Thank you so much, Dr. Zia, for such a great presentation. I think you tried to make it as simple as possible for everyone regarding the fat injection, the types. Still, we'll keep our question to the end of the session. I would like to present Dr. Michel Bache. He is assistant professor Percy Military Hospital in France of the Burn and Plastic Center. It's a trauma center, and his interest is reconstruction of the upper and lower limb and reconstruction of the burn patient. He has two subjects. We'll start by the radiation, burn treatment, a new approach. Welcome, Doctor.
Thank you very much for your invitation. It's a very pleasure for me to join you for these two days. I work in Percy Hospital, which is a military hospital near Paris, and I'm going to share with you our results about new therapeutic approach for radial burn combining surgery and cell therapy. Our hospital is now the reference center for radiation burn in France and elsewhere. I want to accentuate the participation of many different specialists who work together in the same place for the same cause. In military hospital, we are lucky to have all these specialists to take part in this program. Clinical unit, SPRA, and blood center with cell therapy unit. ASN, IRSN, Percy, different departments meet in one place. We have the capacity to organize the specific treatment, personalized regenerative medicine in the case of radiological or nuclear accident. Regarding radiological accident, two main scenarios. The first one is a total body irradiation, so-called acute radiation syndrome. But we will focus on the second, the localized irradiation with cutaneous syndrome, which is a deterministic effect of radiation burn. The necrosis of soft tissue is unavoidable when the dose absorbed is more than 25 degrees. Radiation burn is a specific burn, totally different from burn, thermal. The lesion is dynamic with an appreciable spatiotemporal evolution with successive inflammatory waves. The healing is fragile and uncertain. The deep and paroxystic pain are resistant to opiate, and their occurrence is closely correlated with C-reactive protein. I want to distinguish two periods, before 2005 and after. Before conventional treatment with excision and skin graft. I'm going to present two cases showing the limits and the failure of this treatment in case of high dose absorption. And after, with a new therapeutic approach combining surgery and cell therapy. Concerning the conventional treatment, the evolution is characteristic. After the first skin graft, partial failure can be observed. We did 5 skin graft surgery with a very bad evolution, as you can see. Each surgical operative act seems to stimulate inflammatory waves and boost ischemic and fibrosis process. After 5 skin graft trials and partial failure, flap has been unavoidable. This healing has been obtained after 500 DPE. The patient stayed in our unit all this time. The second case is more dramatic. This is a case of industrial accident with gamma radiation exposure and illustrates the evolutive aspect and failure. We made iterative excision. The aspect of the third picture at the bottom on left slide is characteristic. Each surgical act leads to spread of the radionecrosis that can escape to the surgical treatment. Disarticulation of hip was unavoidable. Despite radical surgery, a recurrence has appeared in the perineum without surgical solution, apart colostomy and ureterostomy. Since 2005, we have developed a new therapeutic approach combining surgery and cell therapy. In some cases, when it's possible, surgical excision can be performed much earlier, guided by dosimetric reconstruction. An example of radiologic source at the right side with gammography source used in the petroleum industry to check the sealing of the pipeline. This proposition is based on successful research by IRSN carried out on mice model with radiation burn healing after MSC injection. In parallel, we performed a pig model in order to compare different surgical process, graft, flap, combined either with stem cells or without. The results prove this new therapeutic approach, surgery essentially by flap combined with cell therapy. Production of clinical grade MSC required a cell therapy unit approved by NSN, it's the French FDA, and a powerful process of cell culture in order to obtain, in a very short time, a high number of stem cells. All of those cases has been authorized in a compassional situation after French agency agreement. I'm going to present the Dakar accidental gammography irradiation in 2006. He has hospitalized at the Percy Military Hospital at day 29 post-irradiation. He presented both an acute radiation syndrome and a severe radiation burns. And severe radiation burns of the posterior part of arm and shoulder. We were waiting, like you can see, many points of spontaneous healing all around the lesion. When circumstances of accident are unknown, it's impossible to make dosimetric map. We observed spontaneous and complex healing of the axilla. You can see the severe irradiation burn was located on the posterior part of the left arm and shoulder. And without good evolution of the arm, we realized excision and artificial dermis graft of the back of arm. But conventional treatment with skin graft was a failure marked with a whole dry necrotic process involving the underlying muscle. We made an important excision of all damaged tissues of the posterior part of the arm, shoulder. You can see the radial nerve and humerus bone, and it was covered by the latissimus dorsi flap, and we used a collagenous layer for MSC support. Unfortunately, we observed a necrosis of the distal part of the flap, which exposed elbow bone. I think it's normal because the latissimus muscle dorsiflap was taken from the left part of body, which was also exposed to radiation. Bone dose absorbed is more than 40 gray. The combination of both surgery and MSC administration is of crucial importance to perform a good soft tissue reconstruction to cover bone. This patient has been exposed to massive dose of radiation, and bone dose absorbed was more than 40 gray. At that time, we thought that disarticulation was unavoidable, and we decided to do only a local surgical flap and to intensify cell therapy. We covered the elbow with a forearm radial flap or Chinese flap, and a third MSc local administration. Here you can see the very complex medical schedule. We obtained healing after 5 local MSc administration and many complex surgical acts. 2 years later, the healing is stable. Shoulder abduction is limited to 45 degrees. Elbow flex of the arm is jammed at 90 degrees. There is no active extension of the hand, but sensitivity and finger mobility have been preserved, and there is no pain. 2 years after the accident, with his family in Dakar. The last case from Ecuador is thigh lesion, because we were able to mark an exact timeline on the exposition source. In this specific case, we are able to make an exact timeline of the exposition source to guide the surgical excision of all tissue under the 25 gray, which is the limit of unavoidable rhabdomyolysis. You see on NMR and the important inflammatory signal. We made an excision guided by dosimetric reconstruction and skin octograph in the same time, combined with the first MSc injection. Unfortunately, the graft failed in spite of 2 other MSc injections, and a 3 latissimus dorsiflap was necessary to cover all the lateral part of the thigh. We made 6 local MSc injections. This picture is very interesting. The treatment's effects vary in dose correlation with the absorbed dose. At the proximal part of the area, which receives more than 25 gray, it's very large and it needs a flap surgery. The second lesion received less than 20 gray, it needs a graft surgery. The third lesion, less than 10 gray, is need cell therapy alone. The last picture is from December 2010, post-irradiation, 18 months post-irradiation. As you can see, we preserve a very good functional prognosis. Let us now see the specificity of hand disease. This patient from Tunisia was involved in an industrial accident with radiation burns to the hands. Surgery was performed on a classic exudative epidermidis. We made a skin graft without excision and MSc injection at the same time. Good evolution and the healing 2.5 months after hospitalization. The patient left hospital and went back home. Unfortunately, less than 1 year later, the patient went back to hospital because he had a lot of pain in correlation with an osteonecrosis of the distal phalanx of the second and third fingers. We used the same procedure, bone resection and a new MSc local administration. Bone dose absorbed is more than 40 grays. At this moment, no recurrence is reported. Radiological burns is a specific topic. Despite cell therapy, perhaps especially because of lack of soft tissues around the bone fingers, osteoradionecrosis is unavoidable with distal disarticulation. We can conclude that the MSc therapy combined to early surgery is a very efficient new approach for irradiation burn treatment. While the role of MSc in this treatment is not clear, we hope they played a terrific role with combined, which contributes to stop the necrosis process of radiation-induced lesion. Our experience is now well known. It has been recognized by the International Atomic Energy Agency for more than 15 years. This cooperation support includes different societies Activities such as French radiological expertise, French medical assistance in response to a radiological or nuclear accident, and participation or organization of IERA training course. Thank you for your attention.
Thank you, Dr. Michael. Now we go for the second subject represented by Dr. Michael also, about the hand burn sequelae in children 20 years experience in Asia.
We're going to change our place.
Can you continue with the third one?
Yes.
For this one. They have this.
We are going to change of country. I would like to share with you our 20-year experience in Southeast Asia alongside Children Action Foundation in terms of sequelae of burns in children. Sequelae of earned burns account for a large part of our humanitarian activity. The young sequelae must be operated as soon as possible before irreversibility sets in. Young children must be operated, follow up, and reoperated if necessary. The aim of the surgery is to restore function, a hand that opens rather than closes, a hand that grasps. But we must not forget the conditions of our activity in the absence of postoperative rehabilitation. This requires simple, reliable, and reproducible surgical techniques. Wide debridement of the hands and fingers with full thickness skin graft is the gold standard. The immobilization of fingers is essential, and the rule is 3 times 1 month. It must be associated with specific treatment of the commissure by local plasties. Debridement is a complete excision of the fibrosis caused by the burn to expose the healthy subcutaneous plane. The term debridement is not to be confused with debridement, which corresponds to the surgical trimming of necrotic tissue. We perform this debridement under general anesthesia, tourniquet with a smart band, and magnifying glasses. The debridement reveals a more or less lot of skin substance. Here, large pulmonary debridement. Pulmonary wrist debridement. The debridement must be little more extensive, up to the limit enlightened by the dotted lines to better free the first commissure. Full thickness skin graft is the best way to cover the hand after debridement. If the inner side of the homolateral arm is the most convenient, but the inguinal donor site is most often used because of size of the skin graft required. The postoperative dressing must be comfortable and modellant with tulle grass dressing, leaving the finger pulp visible. Because of early necrosis of the fourth finger, we no longer stitch bandage to the fingers and fixed the graft with bourdonnet, because they can compromise the distal vascularization by compression. Unfortunately, the fourth finger had to be amputated. Let us see results 5 years later. Radial wrist retraction and the result. Excellent functional result after 9 months. 2 years later. Remember, children must be operated as soon as possible before the distortion set in, dorsum and resurfaçage in this very young child. Even if the result at 18 months is very good, the follow-up during the growth is important. If full thickness skin graft is the rule, semi-thickness skin graft also gives very good results. They are used for larger areas when the inguinal site is insufficient or not available. Despite the thickness of the graft, which guarantee a good functional result, the donor site heals very well. Other result of semi-thickness skin graft. The immobilization of the fingers and hand is done at maximum skin capacity, generally in the extreme position, the opposite of the initial deformity. Fingers in extension by peritoneous broaching is a rule during 4 weeks. At the end of the surgery, just before the dressing, all the pulp coloration need to be controlled. If the pins compromise the vascularization by excessive stretching of the pedicles, it is removed at the end of the surgery. The wrist is immobilized, if necessary, directly with a splint. The immobilization of the metacarpophalangeal joint at 90 degrees requires transarticular broaching. A similar case of dorsal retraction and transarticular broaching. For little fingers, you can use needles which are less traumatic. The pins are removed and relayed by splint. 1 month, day and night, 1 month, night only. The duration of the immobilization follows our protocol of 3 times 1 month. On the photographs, you see resin splint our physiologist brought from France, but you can also use plaster, which exists everywhere. Mixed immobilization with transarticular pining for MP joint while the wrist is immobilized in palmar flexion in the extreme position opposite to the initial deformity by the splint, also for a period of 3 months. Palmary wrist retraction, which impose immobilization in extension. The grafts generally heal very well, but their retraction must be always feared. Here, no splint after the removal of the pins, the child has to be reoperated. We are very often confronted with this situation. Postoperative immobilization is fundamental. The treatment of commissures is specific. Commissures are similar to our functional joint area we'll see in the next presentation, for which a flap is indicated. These commissural plasties are performed in the same operating time as long finger grafts. They are either of palmar or dorsal origin. They can be multiple and associated. First commissure, full finger skin graft is still an indication for the first commissure, or trident plasty can be performed. Other commissure, local plasty like YV, Y incision, palmar V advanced to the top of the commissure. The YV can be palmar or dorsal. It is possible to associate dual V plasty, palmar and dorsal. The V can be drawn as a U, which increases its covering capacity and the vascularization vitality of the flap. This modified V in a rectangular or omega shape is the blow flap. Dorsal blow flap, palmar blow flap, trident for the third commissural space. The ulnar edge of the hand often offers good skin reserve. Here, ulnar IC plasty. An important healthy skin reserve on the lateral side of the finger is a sine qua non condition for local lengthening plasties like SH flap, S incision like a Z, but here the two flaps are not transposed but sutured hand to hand in a H shape. It's a modified Z plasty. Don't forget that a trident combines 3 plasties and is more efficient. In fact, these simple, reliable, and effective techniques we saw previously gives little time for more complex treatment. Burn in early childhood, taking care in adolescence with irreversible osteoarticular tendon damage and deformities that is outdated forms. It is a real problem. 3 elements are absolutely to be taken in account when making the surgical decision. Delays in the initial trauma and the age of the child, clinical examination with careful attention to access passive and active joint mobility and detecting arthrodesis, and X-ray. For this outdated hand, the goal is just to try to restore a grip with partial resection of the thickened metacarp and full thickness skin graft for the revealed loss of skin. This different case of this teenager with spontaneous post-traumatic arthrodesis. Over time, a progressive adaptation is observed over time and solicitation with a thumb index pinch, which is admittedly rudimentary, but with a possible grip. We did not operate this child. Resigning oneself to giving up surgery can create doubt in patients and their family, but also in our local colleagues. Therefore, we must resign ourselves to give up when the surgical care becomes too complex, which infeasible techniques in this precarious concept. Considering the number of children examined, this resignation leaves time for others and thus sets up the functional triage. offering a surgery that is functionally effective for some and for the greatest number, without aggravation other by an inconsiderate and unsuitable gesture. Thank you.
Thank you so much, Dr. Michael. There will be some changes regarding the next presentation will be for the next session of Dr. Mohammed Al-Qahtani. And Dr. Michael will continue his presentation about the burn in children's 20 years experience in humanitarian surgery.
Okay. We previously saw hand CKD surgery, and now I will focus in this presentation on the concept of flap surgery in functional area. Thank you. We have remotely observed insufficient results or even failures on the functional level of grafts in articular areas. Despite the plastic qualities of the full thickness skin graft, as the child grows, further grafts are often necessary. Complete failure of surgery in cervical and axillary area. Secondary retraction of this thin graft without postoperative posture orthosis and lack of rehabilitation after surgery. In this context of humanitarian care. Equally, we have been confronted with exposure of structure which need a flap coverage, like this emergency flap to cover the anterior leg tendon with a very good functional and cosmetic result after 2 years, here also in absence of any rehabilitation. The follow-up of children show that only a flap brings a potential growth which obviously accompanies the growth of the child, but also the recovery of joint amplitude. For example, these two parascapular flaps extend under stress. For each functional area, we'll see clinical case. Cervical region. This young girl has received several iterative full-thickness skin grafts, but the cervicomontal angle remains erased. Debridement must involve the anterior cervical region, and a new full-thickness skin graft could be performed, but we prefer to perform two supraclavicular flap with direct closure of the donor site. This wide bridle in the cervical region cannot be corrected by local plasties. We raised a deltopectoral flap with a very good result 1 year later. The latissimus dorsi flap is great of interest in the treatment of global cervical region retraction. The skin paddle extending beyond the anterior edge of the muscle provides only a skin covering in the neck. If it often allows simultaneous release of the homolateral axillary region, and this determines the choice of left or right harvesting. Its stretching is facilitated by a neurovascular dissection. Excellent functional and cosmetic adaptation of the flap to the cervical region. The coverage of the donor site by a thin skin graft is in a non-functional area, and we have never seen any repercussion on spinal growth. However, the morbidity of the donor site from a cosmetic point of view is certain. The flap was taken from the right side in order to free the right axillary region at the same time. At a distance, it is possible to perform local plasties on the periphery of the cutaneous paddle, particularly in the cervical region, to optimize its spread and improve functional results. Axillary region. For isolated bridle of anterior or posterior axillary pillar, local plasties are useful. Z-plasty, when the skin region on both sides of the bridle are healthy, the Z is drawn across the bridle. Trident plasties offer 3 plasties, double asymmetrical Z-plasty and 1 YV-plasty, and is more efficient. When both axillary pillars are affected, only one pillar should be treated at a time. This child has already had a trident to treat the axillary anterior pillar. 2 years later, a new trident for the posterior pillar. Or even EC-plasty, it is an asymmetrical Z-plasty used in the cicatricial age. The C is taken from the healthy area in the inner side of the arm. Or even the C can be harvested from the thoracic region. The IC allows a large flap to be transposed. The vitability of the C is constant by respecting the ratio length-width by 2. The problem is different in case of global damage to the axillary region. The parascapular flap is a flap of choice. The pedicle is constant in the middle of the lateral edge of the scapula. The flap should cover only the top of the axillary region. It should be sutured under slight tension and extended far forward to the healthy region. In large axillary fusions, the distal tip of the parascapular flap should reach forward to the clavicular relief. This evolution perfectly demonstrates that the flap has accompanied the child's growth and the recovery of joint of motion. Only a flap offers this evolutionary growth potential. Often the donor site of the flap is directly closed, but the inner arm and thoracic region often need to be grafted due to the extensive revealed loss of tissues. But these graft areas are again located in a non-functional area. We can see elbow. The choice of local plasties is based on careful skin examination of and the search for residual skin laxity. EC-plasty is an excellent random flap for the elbow. The C taken from the healthy area is transposed to the burn area. 4 orientation of the EC are possible according to the cutaneous laxity. Knee. The leg is an important reservoir of fasciocutaneous flap. The saphenous and sural proximal flap are very reliable flaps, perfectly adapted to cover the knee, but also the popliteal fossa. Distal pedicle flap are less reliable, and we prefer the lateral supramalleolar flap for ankle covering. The muscle flap, medial or lateral gastrocnemius flap, is only used when there is no possibility of covering with the cutaneous flaps. And of course, it must be always grafted because it should be not harvested in its musculocutaneous version. It is essential to dissociate the muscle flaps from the fasciocutaneous flaps in the leg. This musculocutaneous dissociation increases the possibility of coverage by combining flaps. The revealed loss of skin substance after incision could be grafted. It would be required long and careful postoperative care and rehabilitation to avoid any secondary retraction. For us, a sural flap is ideal for resurfacing the popliteal area. The axis of the sural flap is the lateral saphenous vein accompanied by the medial sural nerve. Both are vested with the flap. Its course is from the lateral retromalleolar region toward the middle of the popliteal fossa. The pivot point is located in the popliteal fossa. Another proximal sural flap. This flap offers an excellent plasticity. In this case of chronic ulceration due to permanent tension, the healthy skin in the medial part of the leg allows to raise the proximal medial saphenous flap. The axis is centered on the great saphenous vein accompanied by the medial saphenous nerve. Be careful, the cutaneous paddle must be drawn behind the medial edge of the tibia to avoid exposing it when the flap is lifted. Rocket-like harvesting can be done for all these flaps. This technical variant avoids the tunneling of the fat fasciopedicle, which is often impossible in these sclerotic tissues with the risk of compressing the pedicle. The pedicle is thus covered at the intermediate incised site by the handle of the racket. No surgical treatment of the acute burn after 1 month. The phlegm inevitably set in. On the left calf, no skin available. We raised a medial gastrocnemius flap for the popliteal fossa with skin graft. The child is walking after 2 months. Ankle. Local plasty are very effective, but they require a significant proportion of healthy tissue and are only intended for moderate damage. They no longer have a place for these more sequelae which need a pedicle flap. The lateral supramalleolar flap is reliable for ankle retraction. It can be raised like a propeller flap, but warning with the importance of postoperative immobilization with a splint to avoid the necrosis of the flap due to stretching the pedicle during foot movements, especially in childhood, and all the more so the flap is made on the manner of the propeller. After removal of the necrosis flap, full thickness skin graft is done. The session should be carried out with magnifying glasses to visualize the pedicle. In this case, the flap only covers the anterior part of the ankle, the foot and the donor side of the flap. Non-functional area must be grafted. We have chosen to present our experience and reflection through a book written in 2021, a book with a rich iconography, a book simple to consult and organized into anatomical regions. We illustrate our surgical point of view and this plea for flaps by using skin plasties and pedicle flaps, reliable and reproducible. You will not find their technical descriptions, but only few fundamental points. We will also come back to the principle of full thickness skin graft and an important chapter of hand sequelae. This is not a treatise of surgical indication, but rather a treatise of suggested indications. Thank you.
Thank you so much, Dr. Michael. I think you are running already late, 15 minutes. There will be no time for question. I may take only one question. If there is any question regarding our speakers. Just before we move to the next session, just one question for Dr. Ziad. Regarding the scar, what is your recommendation as we face, all of us, many cases regarding the scar, whether due to cosmetic for all body contouring or due to burns or all complicated cases? Just a simple way, do you start by the nanofat or PRP or microneedling? What is your way of setting from the result that we see the nice result? Thank you.
Okay, thank you, Mohammed. First of all, we like to treat function before cosmetics. So the function is very important. We have seen very nice presentations regarding contractures. We treat first function and contracture release, then by applying skin grafting, dermal templates, flapping, surgery. So this is a must. And when we treat function, we go to the cosmetics of the scar itself. And the scar is 3D. We see it from the outside, but there is something happening in the inside. So apart from the functional release of the scar, and then the scar will be stable, we do not treat unstable scars. So if there is hypertrophy or keloid, we treat them first, we make them stable. And after they are flattened, for example, we use a lot of dermojetting, and after being stable, we speak with the family or with the patient himself, herself, by applying percutaneous release, and we inject fat under the scar, because if we do percutaneous release, there is a gap between the scar itself and the bone or the muscle. So we like to make filling right now. But later on, we try also to rejuvenate the upper layer of the scar, which is the most important indication right now. How we reach this very upper layer, only 1 millimeter. So if you use even the micro cannulas, you will go a little bit deeper. So what is happening right now is that they like to inject the nanofat with the microneedling system. Therefore, we go from outside and we pressurize the scar itself through the microneedles. They are 36 microneedles, and the nanofat is coming. So after we do that, this is all in the operating theater, because I like to do the harvesting in the OR, not in the clinic. We stick with the patient. We make a consent also that the patient must come after 4 weeks to our clinic for platelet-rich plasma therapy. And this is very important, because PRP makes survival for your fat grafting, and it increases the survival rate for the fat grafting, even if you do the best for the fat graft and the best processing. According to the literature, it is better to do it 2 times or 3 times consequently. I do it in my practice 4 weeks later, and another 4 weeks later, and another 4 weeks later. And then I don't leave the patient. We make some connection with our nice dermatologists because they are good in CO2 laser. And I believe fractional CO2 is a very good technique if used in the best time. And right now, it is the best time because the scar is already nourished, treated functionally, cosmetically from your side, and then they come to me back. And right now, we are speaking about 5 months or 6 months in the journey, and we see such results.
Thank you so much. Thank you, Dr. Eduardo. Thank you, Dr. Michael. No more question. Yes, doctor. We'll keep it for the next, maybe for the next session, the question. I will go for the pediatric burns for the next session. I'd like to call my colleague, Dr. Hatem. He will be the moderator. Please, Dr. Hatem.
And I welcome Dr. Hatem Al Nauman.
Hi, thank you so much. I'm Dr. Hatem Al Nauman, plastic surgeon, pediatric plastic surgeon at National Guard Hospital, Jeddah. Thank you for the organizing committee for inviting us. I would like to reintroduce my colleague, Dr. Eduardo Goos, who's a staff plastic pediatric surgeon at Sick Kids Hospital, assistant professor at University of Toronto. He's gonna start the pediatric burn panel with a lecture called the differences between pediatric and adult burn. And the second lecture will be the outpatient consideration in pediatric burns. So Dr. Eduardo, the mic is yours. Thank you so much.
Thanks, Hatem, for the introduction again. And so when I was invited for this talk, they suggested that I spoke about the differences between the practice in adults and pediatrics, recognizing that I have had an appointment in an adult burn unit and now I'm doing pediatrics. So this is basically my experience. I did my basic training in Brazil, which is where I come from. Did a number of fellowships in Toronto where I met Hatem. Then I had an appointment in Australia, and now I'm back at in Toronto at Sick Kids. I'll start talking about the similarities about pediatric and adult practice. And basically, and the most important one is that as it has been said previously in this room, burns requires a holistic, multidisciplinary approach. Doctors won't do anything without the nurses and without the therapists, occupational therapists, physiotherapists, dietitians, etc. Burns requires a multidisciplinary approach. The difference really in pediatrics is that we, particularly in Canada and some places in the US, we use the child life specialists as well, which is a type of professional that tries to normalize the environment for pediatrics. And we're going to be discussing this a bit in more detail. So the values and the principles are the same. The practices may vary a little. So to begin with, the nature of the injury is very different. So when we're talking about adults, we're talking about big flame burns, major burns, while in kids, we're talking about scalds and small injuries. So donor sites are usually not scars. There's a huge potential for spontaneous healing. And in terms of ratio, male to female ratio, in the adult population, there's a lot more in men as opposed to women. In the pediatrics, it's still not one-to-one. You know, boys will be boys, but it's much more similar. And again, in adults, it's either related to work. The injuries are done in the workplace, or it's related to abuse of drugs and alcohol. While pediatrics is quite different. So kids are unaware of the hazards and they're trying to explore the world and they end up doing silly things. And obviously there are the adolescents to which all of the above apply. They do silly things, they do drugs, they burn themselves at home, at school, at work. And this is a classic sentence that probably you have heard a number of times before. Children are not just small adults. Their physiology is quite different, and that applies to burns as well. So to begin with, their skin is much thinner than ours, and they require a less of duration of contact to the insulting agent to develop a full thickness burn. On the other hand, they heal much better than us, which can be quite a challenge, because usually on day 3, if you're working in an adult burn unit, you can tell if the patient needs surgery or not. Whilst in kids, they surprise us very, very often. And there are some burns that you could swear they would require surgery, and they heal nicely. So you need to be conservative with them. The other difference is that they have a much higher BSA to weight ratio, so they run into hypothermia issues very, very quickly. And because of the limited glycogen reserve, they also get hypoglycemic very quickly. Obviously, kids are vulnerable, and it's up to us to advocate for them. They can't make decisions on their own, and there's a major concern for abuse and neglect. And for anything that you can think of, from diagnosis, treatment, prognosis, anything about pediatric care, you need to think about the developmental stage. Treating a 2-year-old it's a completely different experience than treating a 10-year-old and treating a 16-year-old. So the practices varies because of that. And to begin with, you're treating an entire family and not just the kid, because they will require admission with their daughter or their son. And there will be sentiments of guilt, and they will be overwhelmed with care, and they will miss work, and they have other kids to take care of. And all of that will play a role in how you do your work and why you do what you do. So in the best interest of the time, I'm not going to go through the entire ABLS or the EMSP, but I will point out the major differences that you have to be mindful in pediatrics when we talk about major burns. In airway, they have a very small airway, and they obstruct really, really easily because of the size of their heads and the shortness of their neck. Abdominal breathing in adults is a sign of respiratory distress, and it's absolutely normal in pediatrics. This slide is really to remind you that in most adult burn units, you're going to start resuscitating them when they're greater than 20% TBSA, but in some cases, and we do that at SickKids, we start resuscitating them if they're greater than 15% PSA. Again, hypoglycemia in disability. You should remember to remove the diaper and to look into the scalp. Those are the 2 major areas that are missed by inexperienced practitioners. And be mindful that, again, they run into hypothermia in no time. And again, if the story doesn't match the pattern of the injury, you should have in mind that this can be abuse or neglect. So this is an 18-month-old that is still admitted at SickKids. It's a patient that I admitted 2 days before I came here. And the history was a scald burn, that she had bruises because she was learning how to walk, and she fell onto a tub with hot water. When you can clearly see on the left cheek, there's a smiley face. That's the pattern of the injury. That's not a scald burn. I can't tell if this is a contact burn or if it's a chemical burn, but I can assure you it's not a scald burn. So the skeletal survey of this kid revealed multiple fractures to all extremities. She had an intracranial hemorrhage as well, and she's still admitted. So have that in mind. That happens, and it happens all the time. And it's a great reason for you to refer to a regional burn center, because part of the multidisciplinary approach of the burn center is to work with social workers who are able to detect this, who are able to treat this. And it's only because in a burn center you find experienced burn surgeons that they will be able to tell, no, sir, this is not a scald burn. Maybe in a community hospital, you're not going to have the ability to emphasize this. In terms of burn assessment, you should always keep in mind that the head is disproportionately large, the legs are disproportionately small. So usually the rules of nines is not great for pediatrics. And because most of the injuries are small, less than 10%, what we like to use is the Palmer method, which is 1% the entire area of the palm of the patient, obviously. That works for any age, including adults. This is just a reminder that being mindful of over-resuscitation, the American Burn Association has decreased the rate of fluids for you to begin fluid resuscitation in pediatrics as well. And 4 mils per kilo per hour is only for electrical injuries. You should begin at 2 or 3, and obviously titrate according to organ perfusion surrogates. Another common mistake that we see in pediatric emergency departments is that they titrate both the Ringer's lactate and the maintenance. But maintenance fluid is only for kids that are smaller than 30 kilos, and it should not be titrated. You weight them, you start them on 2 infusions. The maintenance fluid should be constant, and it's the Ringer's lactate that should be up or down titrated according to urine output. The other very common mistake, and thanks God, major burns are very rare in pediatrics, is that they like usually the EDs that are not used to receiving these patients, they over-resuscitate them very easily. And although you don't want to under-resuscitate a kid because their kidneys will fail, if you over-resuscitate a kid, they will run into much bigger problems, compartment syndrome of the limbs, of the abdomen, and cerebral edema, and they die. So that happens in peds, and it should be prevented. There's no good treatment for that. Okay. Escharotomies are rarely needed in pediatrics because, again, there's usually scald burns, but eventually you will need to do them. So you have to keep in mind that it does happen. In terms of analgesia, the main take-home message that I want to bring to you, this is the obvious part. Burns are painful. That we all know. But what not everyone knows is that morphine is the gold standard medication for burns, for adults and for pediatrics as well. Parents are afraid to use morphine, to give morphine to their kids. They hear about the opioid crisis. They think their kids are going to get addicted, and that does not happen in pediatrics. Okay, there's a lot of practitioners that would prefer to give codeine to kids because it's the milder version of morphine, but up to 30% of the pediatric patients lack the enzyme that convert codeine to morphine. So you are under-treating 30% of your patients if codeine is your medication of choice. This is just a very nice article that showed that management of burns with higher doses for kids between 1 and 4 years old is associated with decreased signs of anxiety and depression in the future. And there's this other article that says that the same thing applies to older kids as well. And this is I think it's the last slide of this first part of the presentation, and that's on purpose. It's some of you are not familiar with child life specialists. They have a training that derives from psychology. They learn about development, and their goal is, one, to provide distraction to the kids, which is extremely helpful during dressing changes. And I love this picture because it's our child life specialist making bubbles while we're taking a dressing down. They normalize the environment, and they have coping strategies not only for the kids but for the patient, the parents as well. So they're an integral part of our burn team. And I guess with this, I'll finish the first part, which is really the reasons why we do the treatment the way we do. We're going to talk about this in the
Yes,
next.
please. Yes, please, we can proceed. Thank you so much.
Here we go. So treatment considerations, and that's obviously based on all these differences that I just mentioned. So this is the, on the left side, you'll see it's the American Burn Association Burn Center referral criteria, which is pretty similar to the European and to the Australian, and I assume that's similar to the one in the Middle East as well. And we're all very familiar with. The red ones, the ones in red are the ones that we see most often. And there's a huge difference between the referral criteria and the admission criteria. And our trainees, when they first start the rotation at SickKids, they get really confused. They guess, well, this patient has a severe burn to the knee, which is a major joint. Why are we not admitting this patient? It was like, these are two separate things. So the referral criteria is, you work in a community hospital and you are seeing a burn for the first time. This burn needs to be assessed by the experienced burn team in your region. So you will refer this patient to the burn unit. That doesn't mean that the burn unit needs to treat them as inpatients. So this is what we advocate. On the left side of the screen, you're seeing the referral criteria. On the right side, it's the criteria that we use for admitting the patients. Okay, so obviously severe burns, and I'm not only here talking about a 50% TBSA, which is obviously going to be admitted anywhere, but sometimes smaller burns, which may not seem severe to us, are extremely severe and overwhelming to the parents. So you can't just let them go because they won't take proper care of their kids. So if the care is overwhelming, that equals to a severe burn, needs to be admitted. Pain control is another great goal for our admission criteria. Critical areas, and with that I mean basically faces and perineums, because faces and perineums are areas to which you really cannot apply dressings. If you know about good dressings for perineums and faces, please let me know, because it's really hard. And obviously, so for social reasons. So if there's any suspicion of abuse and neglect, you keep them as inpatients until this social situation is sorted out. So what I'm trying to say is that we treat most of our patients, basically 90% of our patients are treated as outpatients. And we understand that at home, kids heal better, they eat better, they play with their toys, they are in the environment that they feel comfortable, and that contributes to the success of the outcome. And the reason why we can do that is because we used closed dressing techniques. So closed dressing techniques, by definition, is really applying dressings. Usually they're silver-based. They have antimicrobial properties, and they can stay in place for up to 7 days. Okay, the ones that we use at SickKids are Acticoat and Mepilex AG, but there are no hard evidence saying that these are better than any other silver dressings, and you can do it with whatever silver dressings available at your institution. So for wounds that are not too deep and that they have that natural exudate of superficial partial to partial thickness burns, we apply Mepilex AG because it's a foam, it's conformable, it manages the exudate, and it's great for those burns that you are seeing and that you're thinking in 7 days from now, this burn will be healed. So you can take that dressing down in clinic. They don't need any sedations. Acticoat has much more silver content. It needs to be irrigated in order to be active, because if it dries up, you no longer have ionic silver onto the wound. So basically, this is the schematic diagram of our model of care. We see our patients on day 0 in the emergency department. We don't use silver dressings at this point. We just use a simple Vaseline gauze dressing for 2 reasons. The first one, the burns will still progress in the first 48 to 72 hours, so you don't know exactly what is the definitive depth of your wound. Then we allow the wound to progress on the first 2 to 3 days. We bring them back to the burn unit and we sedate them. And we sedate them every time we do dressing changes in pediatrics. Sometimes the parents won't agree or will ask a number of questions. Why are you sedating, giving general anesthetics to my son these many times? And again, you go back to those arguments about PTSD. And there's a survey that was published on adults who were burned as kids. And their memories is those memories of horror movies, of alien abductions. Like there's like a number of people with masks around you manipulating parts of your body while you're in a huge deal of pain. So we sedate them on day 3. By that time, the wound will be totally declared. We'll define if we're going to use one or another silver dressing. We'll see them again on day 10. And at that point, we make the decision. If this is going the right direction, this kid will be healing in the next 7 days. We'll see them in clinic and just we'll take the dressing down with PO, Tylenol, or morphine, as the burns are going to be healed and they're not going to be in a lot of pain. Or we're going to schedule the next dressing change in the OR for a dressing change plus or minus excision and allografting. So the thing about pediatrics is that because they heal so much better than us, and because we really have a hard time predicting if they're going to be spontaneously healing or if they're going to require surgery, we have to be conservative. And as we are conservative, we are giving up on the opportunity of operating a burn wound that has been open for 2 to 3 days and it's not highly contaminated. And we're going to be operating on a wound that has been open for 16, 17 days. And there's a much greater burden of bacteria, and that decreases the chances of grafting success. So we use a staged procedure. And we allograft pretty much 100% of our patients as the first procedure, and then we sheet graft them. So allografting turns a contaminated wound into a clean or a cleaner procedure. It decontaminates the wound, decreases the bacterial burden. It also tests the wound bed, because if the allograft, which is cadaver skin with different genes that has been frozen for a number of time, if that skin took, the patient's own skin will take for sure. And it also minimizes the risk of fluid collection. We advocate for sheet grafting to all of our patients, or most of our patients, obviously not the major burns in which we won't have enough sheet grafts. And one of the reasons is obviously cosmetic. We want to avoid the appearance of the mesh grafts, but most importantly, and this point was just touched by the previous speaker, is the fact that you may have a great result on a 2-year-old for 1, 2, 3, 4 years, but at some point they will undergo the growth spurt, and then the grafts won't grow as much as the adjacent skin, and they will develop scar contractures in the future. So if you sheet allograft them, you're not preventing 100% of them, but you are minimizing the chances of this happening. So this is a basic example, classic scald pattern, face and shoulders. Day 0 in the emergency department. They come back on day 3 in the OR because it's a small kid. And if we were working from an adult burn unit, we would say, well, this is pretty dry and has a lot of hemorrhagic staining. This will require surgery for sure. But we are conservative. So we wait, they come back for another dressing change, and you confirm that, well, you know, indeed, he will need surgery to both shoulders, and the face is already going the right direction. So we see this kid again in the next week in the OR. Indeed, there will be patients that at this point will not need surgery, although you thought they might need. But even the patients that do need surgery, this is the original size of the burn, and this is the size of the graft that we're doing. It's it didn't minimize as much as the other side on the right side, but you can see you minimize the area of surgery, you minimize the risk of contractures down the road. So we allograft first, again, because it's been contaminated for over 2 weeks. And they come back now the following week for autografting, and this is the graft takedown. Final result. The one last point that that I want to make is using allograft as a dressing. And Sir Gillies, one of the fathers of plastic surgery, was the first one to say that skin's the best dressing. And we do that quite often with our kids. So again, because there is no good dressings for faces, and what we suggest is face care, which is basically clean up the area and apply Vaseline at least 3 times a day. This is a great strategy. You take them to the OR, give them an anesthetic, lay a nice sheet of allograft on top. It will stick to the wound. It will, as if it were to integrate. And when the wound is fully reepithelialized, it will fall off spontaneously. So this is great for pain control because the nerve endings are obviously covered, and there's no building of exudate. So this is a case of a 16-year-old who was smoking close to a propane tank, and there was an explosion. So he had this pretty severe face burn. I bet that most of you would agree that this looks at least deep partial thickness, dry, and with hemorrhagic stain. So we did that. We brought them to the OR, covered all the wounds. We never cover the upper lip because of the nasal secretions. It fails 100% of the times. So we did this, and this is how the patients heal after allograft. So I guess Sir Gillies was right. So in summary, these are my suggestions, and this is what we teach at SickKids. Try as much as possible to treat your patients as outpatients. They eat better at home, they feel better at home, they need less morphine at home, and they heal quicker at home. In order to do that, use close dressing techniques with silver content. Always stage your procedures into allo and autografting. It does increase cost. It does increase length of treatment in a week, but it does increase your chances of success, close to like almost 100% really. Sheet grafts are not only more beautiful, they're safer, and when they grow up, they're going to be very thankful that you didn't mash those grafts and use allo as a biological dressing. Thank you.
Thank you so much, Dr. Gose. You summarized all the important aspects in pediatric burns. I hope this will help in changing practice in the all burn centers. Unfortunately, in our countries, usually we don't receive the burns to the tertiary centers immediately. Usually they got delayed in other burn centers. Usually they present to us very late with a picture of septic shock and very contaminated wounds. How would this differ your management if the kid comes to you in septic shock with very contaminated wounds, especially like major burns? Is that makes it any different?
Well, that's a completely different scenario because obviously then you just need to remove all the wounds in order to get the source control, right? You have to
Right.
eliminate the source of infection. So this is not the ideal scenario. I think the really what you should try to spread the word is in creating or adopting the referral criteria. So
Right.
these kids get to the burn unit as soon as possible when you can maximize their outcome and operate on them while they're not sick.
Yeah. Hopefully one day it will work. Like we don't really have a good referral system here, but hopefully soon, inshallah. Thank you so much, Dr. Goose. Thanks for your time. So now we have Dr. Derek. He's going to present his next talk, the single-stage biosynthetic cellulose dressing, EpiProtect, and his experience with this dressing in pediatric burns. Dr. Derek is a pediatric plastic surgeon. He works in a Jalila Children's Hospital. He's a British and American trained pediatric plastic surgeon. Welcome, Dr. Derek. The mic is yours.
Thank you, Dr. Haitham. Warm welcome to you all, and it's my pleasure to be here. I'm at Jalila Children's Hospital in Dubai, and today my talk is focused on this particular product called EpiProtect, and its difference compared to traditional dressing methods. And this follows on really well with Dr. Gus's talk and the principles. So the talk is single-stage EpiProtect application versus traditional dressing concepts in pediatric burns. I have no conflicts to declare. I don't have any financial interest. This is purely my own or our own institutional experience, and I'm here to present that here. The aims of today's talk is to talk to you about the dressing, show you some examples of my cases, the results, some key points in making it work, and how it improves pediatric care, and finally, some key take-home messages. I'd like to divide the whole talk into the traditional and the EpiProtect. So traditional, you have all these various dressings, products, the creams, the ointments, Mepilex, various products. I love them all. They all work, and I've been using them for many years. But the issue with all of them is that they need to be applied every 2 to 3 days or 4 days. The child is in a lot of pain every time they come for the dressing. The parents are distressed. You are distressed. It's just a very unhealthy environment to do these dressing changes. So this is a product. It's called EpiProtect, and it's actually a substance derived from plant. It's a plant-based material. So there's no animal or human tissue. So it's completely accepted by a lot of families here in our region. It's a sheet. It's easy to use, transparent, and it allows fluid exudate. It's really comfortable to the child, and it works really well in pediatrics. The component is called Iratix, and it's basically a nano structure that mimics human skin, and it creates a scaffold like a substance over the skin. It is also permeable to water and oxygen. So how do you apply it? First of all, let's go back to basics. First aid, really important. Check the wound, assess the depth of the burn, thoroughly debride the burn. The nice thing about this is it can be applied in the emergency department. You don't need a GA, just a sedation is fine. But the key is thorough debridement of all the blisters and the ulcers. You then remove the EpiProtect from the bottle and stretch it and apply it generously over the wound. It's like a skin graft. It has to be completely covering the whole area. You remove any air bubbles and think about splinting the area as well. And then Once it sticks beautifully. You don't need any staples or sutures. You can if you want, but then you put a secondary dressing on top, like Gelonate or Bactigras, whatever you want, and a lot of pads to secure the dressing. So this is my experience. I started to do this in October 2020. Before that, I was using the traditional methods that we discussed. We started using this in the emergency department under morphine or like midazolam sedation. The dressing is applied, so it comes in a little bottle. It comes like a sheet. You pick it out, and then you apply it flat across the burn. I check it once after 48 hours, just once. And then after that, I just see them a week later. So there's less need for repeated dressing. So first dressing, 48 hours, second dressing 1 week later, third dressing the following week. So just weekly appointments. Let's show you some examples. So this is a patient with a hot water burn on the forearm. So we thoroughly debrided the wound, applied this EpiProtect over the area. This is over the wrist joint. So this is my early mistake. I did not splint the wrist. And then I realized that the sheet had displaced. So now I advocate splinting for all areas over joints. So just think about like a skin graft. And the nice thing is that in a week's time, it becomes like paper. It disintegrates. And every week you see it becomes looser and looser and looser. And ultimately in 2 weeks, it becomes completely healed. It's great for parents and children because you're not manipulating the wound at all. All you're doing in the clinic is just saying hello, removing the outer dressing, check it, and then reapply a new padding on top. So parents love it, children love it. You're not traumatizing them every time with manipulating the wound and exposing the nerve endings. And then in a couple of weeks' time, it heals. This is the second patient. He had about 7% hot coffee burns. This was brought to us from another hospital. So after thorough debridement, we removed all the blisters. We applied a large sheet of the EpiProtect. It comes in two sizes, a small and a large. And then you pad it extensively with a large Gelonate or a non-adherent dressing. This is after 2 days, it's well stuck. And then after 4 days, after 1 week, you can see it's starting to peel off. A couple of points. If it is peeling off, that's good. That means it is already healed underneath. If it is still stuck, you don't touch it. You just let it heal and tell the parents, come back again after 1 week. And every week you see them, it gets looser and looser in time. Occasionally, you'll find some collection underneath the sheet. If that's the case, it hasn't been applied properly. You can snip the layer and let the fluid out. You can leave it alone or apply a new sheet on top. And this is a week's time. It's healed in 10 days' time. So usually it takes about 2 to 3 weeks for a complete healing, depending on the depth of the burn. This is another patient with a hot iron burn. This was a little bit more deeper on the volar forearm. As you can see, the whitish layer of skin on the wrist. After debridement, we applied a large layer of EpiProtect. You can see it's very transparent. And in this case, we used a splint as well. And just note that the deeper area here over the wrist has taken longer to heal. So that does take an extra 1 week. So usually the deeper mixed depth burns take longer, about 3 weeks to heal. But it's very patient friendly and you see them less often. The children are less distressed and less anxious. This is another hot water burn, a large one after debridement. And you can see this starting to separate off gradually every week in 2 days, 3 days, and 10 days, and it's completely healed after a couple of weeks. This is another one on a hot tea burn on the foot after application and splinting, and you can start to see it separating very, very gradually. Another one on the forearm, on the arm. This one required a bit more debridement. So nice thing about this, you can apply this in the emergency department, take your time, debride it thoroughly, apply a large sheet. You can overlap the sheets as well. That's fine. It will just gradually get loose and it comes off in time. This is another one on a hot water bucket on the knee. So it can be applied generously over the joints. Think about splinting and review them just once a week. And that's good enough, to follow up the progress of the wound. I've started using this also for my skin graft donor sites. Really good for that because it helps with the pain, helps in management of the area. And in a couple of weeks' time, it's completely lifted off and healed beautifully underneath. So that's another excellent application for this as well. This is another one on the hand, which I've used in a slightly older child. We trimmed it, and then we applied a splint, and in a couple of weeks' time, it completely lifted off and healed. So the key points is you have to think about it like a skin graft that's available to you. So debride the wound thoroughly under midazolam or morphine sedation. You can use a large sheet. Think of it as a method to cover all the areas with a lot of padding on top. Please think about splinting. You can give antibiotics as well. And the important thing is that you are only changing the outer dressing. You're not changing the wound. You're not touching the skin. You're not manipulating it at all. So there's no pain or very little pain at all. And I changed my protocol to just the first clinic review at 48 hours and thereafter once a week. And that has reduced our appointments, reduced our need for repeated consumption of materials. We did a little study. We compared our protocol before we introduced and after we introduced. We studied pain using the visual analog scale and parental anxiety. We found a significant difference before EpiProtect and after EpiProtect. And we think that this is because we're not touching the wound at all. You're just touching the outer dressings. So children are really comfortable. And even parents are also relaxed because they can see that the child is comfortable and they're not distressed. So if we have a very high level of parent acceptance of this technique, on this product. Healing time was almost the same. I don't think there was anything significantly different between what we were doing before and now, but the patient's pain, comfort, and acceptance is so much better with this technique, with this option. When we look at our scars, we actually found that the scars were slightly better with the Vancouver scar scale using the EpiProtect method. We think that that's because the inflammation is so much more lesser, there's less manipulation. And of course, this is very early on, and I'm following up our patients for a long-term study. So just to summarize, this is a single-stage application, can be done at the time of the burn or within 48 to 72 hours following a debridement in the emergency department. It can be used for superficial burns and mixed depth burns. When we looked at our dressing changes, we found a significant reduction in the number of dressings required because we're only using it once a week. And so you can reduce the cost and the number of visits. And in that sense, it's more cost effective. This is also important, thorough debridement, use a large sheet. And then the benefits to the patient is a single stage, less pain, less anxiety, no need for disturbing the burn surface, and it's comfortable. Benefits to the hospital is a happy patient, less need for repeated appointments, less consumption of dressing material, it's patient-friendly, and parents are also very relaxed when you have this option. So this is our first study done in this region. We have found that it is safe, effective, and has less pain. We recommend its use in superficial and mixed depth burns only. For the deeper ones, you would need to assess repeatedly and see the progression at week 2, and then decide if that's going to heal with traditional or the operative methods. For those who are interested, we published this, and this has been published in the Burns Open, and it's available online for free download. So you can read this, or you can approach me for further information. So these are some references, and yeah, thank you for your attention.
Thank you, Dr. Derek. Actually, I've used it on 2 pediatric patients, and my own experience is really good. The dressing is transparent, it's highly absorbent to the exudate, and it soothes the pain. You can use it for as an outpatient dressing for pediatrics. Maybe just one point is before applying it, as you said, proper debridement, cleaning with soap and water to minimize the bacterial load in the wound. And yes, I'm happy with the dressing actually. If maybe you're worried about infection, maybe you can put on top of that silver containing dressing, I guess.
Yes.
So yeah, so I don't know if any of the surgeons have you. Yes, Dr. Goose.
Question. Thanks, Derek, for the presentation. I really enjoyed it. I was really interested. I was looking at the stand, and I think it looks like a great strategy. My question to you, it does remind me of BioBrain a little bit.
Yeah.
In terms of substitute, an epidermis substitute, right? But BioBrain should be acticoated on top,
Yes.
right, to protect from infections. Do you need to add any antimicrobial coverage for this dressing?
No, we don't. So the differences here with BioBrain is that BioBrain is porcine, sorry, a bovine derived. It needs to be done under GA. It needs to be tightly stretched and fixed. And then and there's a slightly higher risk of infection, so you need to have antibiotic coverage. This one is different. This is plant-based. It can be done in the emergency department under sterile conditions, but in the ER under sedation. You don't need any antibiotic or antiseptic coverage. I mean, for these ones, I've used Fusidin ointment just as an ointment, as a topical antibiotic, and a non-adherent dressing on top. I've occasionally covered them with oral antibiotics if I felt that there was some contamination, especially in our patients. They come from other hospitals, at a delayed time. So in my experience, I have not felt the need for giving, topical antibiotic coverage. Yeah.
Just one question for me. Have you seen any infection with or worsening of the wounds?
I've seen this one patient where it was slightly worsened. That was probably because the burn was a bit more deeper than what I was initially suspecting. So it was probably deep dermal.
Okay.
It's not really infection. There's like a yellowish collection of fluid underneath the product.
Right. Which is exudate, or fibrine and exudate.
Yes,
Okay.
yes, yeah. So that's all. So and if it is if you are suspecting any infection, you can still take the whole thing off, wash it, clean
Exactly.
it, and reapply it.
And you can easily detect it. It's transparent.
It's
so you can-
transparent.
Okay.
Yes.
So, doctor, yes. It's not. Your mic is not working.
Well, we have used already EpiProtect in our center at the Armed Forces Burn Center at Helmia Hospital, and we have good results as well. But I think I agree with Dr. That you should put something antiseptic over it to
Yes.
guard against the infection, so you can get a better results. And I have found that in a European burn course in Netherlands. I see that they use the Acticode over it or any
Yeah.
silver dressing.
Yeah.
This will give an antiseptic solution to guard against the infection
Yeah.
and will enhance the results for you. So for physicians who want to use the EpiProtect, I recommend that it's better to put an antiseptic like Acticode over it.
Sure.
They will get good results for that.
Yeah.
And you can cover larger areas as you wish.
Yes.
Yeah, thank you.
Yeah. Thank you.
Thank you. We have lots of questions. Second question is here.
Yeah, I have a question. Any experience regarding using this EpiProtect post-surgical debridement for deep burns before applying the graft? So, for example, we can put the EpiProtect and wait for
As a
like 1 week
temporizing
and
measure.
then we use it
As a temporizing measure before skin grafting.
for skin graft.
Yeah. I don't have any experience in that, but I believe it has been used in that sense, and it has been used as a temporizing measure because it's a plant-based material and it also stabilizes like a biological dressing. So you can do that, but I don't have any personal experience with that.
Next question. Yeah, we have Dr. Gahtani. Yeah. Sorry.
Thanks, Dr. Derek. I have a question about this EpiProtect. Does it help in pain management? If it's
Yes, it does. And you can see it instantly. It creates like a cooling effect on the skin that the kids, they kind of go to sleep and they feel very relaxed. It's something about it, the temperature is so cooling and soothing, and it sticks immediately like a sheet. So that also covers the nerve endings, and it's very, very comfortable. So it reduces the pain drastically.
Next question.
Thank you very much for your presentation. My question, you applied this EPI product directly at the same time of the burn, or you need to know the stage? As you know that sometimes you cannot detect the stage of the burn.
Yes.
So you need to wait sometimes 24 hours or apply directly. And
We've
if you have
applied-
experience with that?
Yes.
I need your experience.
So in our center, we apply it directly. When they first come, we assess the burn, we debride it thoroughly under sedation. And at that stage, we know more or less the extent and the depth of the burn, and we make a judgment and we apply it directly. We have had a couple of patients where they've come late, they've been treated elsewhere, and they've come at day 3 and day 4 with other ointments and other dressings. In those cases also, we've had to debride everything, wash everything. Most of the time, it's fairly clear which depth it is, either second degree or deep second degree or third. I wouldn't use this for a third degree, but second degree and mixed depth burns are ideal for this dressing.
Thank you very much.
What I've noticed also, it makes the burn wound after a couple of days makes it dry. So this might stimulate the kid to scratch and feels, the itchiness. So maybe it's a good idea to add antihistamine or bring the kid to moisturize the Ibuprotect on top of that, like Vaseline or Fusidine. Maybe it helps with the symptoms of itching.
Yes, that's a good idea.
Yeah.
Yes, you can use it.
Yeah.
Yeah.
Any more questions? Yeah, one more question.
Thank you, Doctor, about your presentation. I want to ask, this is one type of occlusive dressing.
Yes.
How we apply some sort of anti-infective over it? It can reach to the burn itself, like a suggestion to put silver or something like this?
Yes, it does. Yeah, this is semi-permeable. And so the material, whatever you put, any ointments or any material can seep through that, and it does reach the burn wound.
All right. Thank you so much, Dr. Darek. Thanks.
Thank you.
Thank you for a great talk. Now we have the next talk, Dr. Hadil Al-Jahani. Dr. Hadil, she's presenting about examining the effectiveness of burn care practice in emergency unit in Saudi Arabia, a pilot study. Dr. Hadil, the mic is yours.
How can
This is the next.
Okay. Is this the mic?
This is the next. You can do that.
Okay. Good afternoon, everyone. I'm Hadil Al-Jahani, sixth year medical student, and today I will present our study titled Examining the Effectiveness of Burn Care. Okay. Examining effectiveness of burn care practice in emergency units in Saudi Arabia, which was a pilot study. And this is going to be the outline for today. Okay, so regarding the background, burn is one of the most significant health issues worldwide, and it has a lot of morbidity and mortality. And in Saudi Arabia, we don't have much research regarding this topic. And the aim of our study is to evaluate the level of burn care that is given to emergency patients by emergency physicians in Saudi Arabia, and whether or not they're following the World Health Organization guidelines. So a rationale is that this study will assess the different aspects integrated in tending to burn care cases in the emergency department. And this fundamental insight highlighted the weaknesses that we must improve and the strength that we need to maintain. Our variables is the level of compliance of physicians regarding the international guidelines. So regarding the methodology, the survey took place in the Saudi Society of Emergency Medicine that was held in Dammam in February 2020. And the population or the main attendees of the conference were emergency physicians, residents, specialists, and also general practitioners, and also students and interns. And they were the inclusion criteria, the emergency physicians, and our exclusion criteria were the students and the interns. And regarding the design, it was a cross-sectional and observational study. So the data was collected using an online questionnaire, which was IRB approved, and the questionnaire was distributed by 2 volunteers at the conference, and also we sent it out to those who did not attend. And the data was entered and analyzed using the SPSS software. And regarding categorical data, it is presented using frequencies and also percentages. And we applied appropriate inferential statistics using the chi-square and the Fisher exact test. And any p-value less than 0.05 was considered significant. And this is our questionnaire. It included 24 questions. We asked demographical data regarding the level of practice, where they attended their jobs, whether it was governmental, private, or both. Okay, so when we assess the demographics, the level of the training of the physicians, as we can see, 37% were residents and almost 33% were consultants, and the rest were general practitioners and specialists. And when we asked about the population who have fellowship in trauma, only 8% said yes, so 92% answered with no. And regarding the institution type of the population, the majority were in tertiary healthcare centers. And also when we asked about the administration, the vast majority were in governmental administrations. And now moving on to the results, the preparedness of physicians in managing burn patients. So 68 of our participants said that they prioritize their patients as they do to other trauma patients. 70 claim to follow the burn guidelines, and 51 do not feel that their knowledge is enough. 39 treat their patients, and 50 refer them. And moving on to our results, the physician's knowledge toward the burn management, and when we asked them if they do manage their patients according to the WHO burn guidelines, 77% said yes. And when we assessed their initial management, so as we can see, 45% said that they washed the burned area with cold water, and only 20% answered ideally according to WHO guidelines. That they apply ABC, assessing burn according to BSA, and antibiotics, IV fluids, and others. And when we asked about how they assess the severity of the burn, so the vast majority answered that they do with the depth of the burn, and only 18% answered ideally that they assess the burn with a mixture of all of the above, the involvement of the primary area and degree of burn. And when we asked about whether or not they know the hospitalization requirements, only 14% answered ideally, and they picked all of the above. Moving on to our discussion, upon analyzing our data, it was revealed that only a quarter of our population abide by the guidelines, and only half of them feel their knowledge is sufficient, with a p-value of 0.108. And upon applying our inferential statistics, these are one of the most important relationships that we got. So the investigations showed that physicians who claim to have insufficient knowledge refer their patient rather than treating them, with a p-value of 0.002. And the study also revealed a significant correlation between physicians who claim to have sufficient knowledge and area of practice. And also we found a correlation between the presence of a burn unit and the perception of sufficient knowledge to treat burn patients. And moving on to our discussions to discuss similarities. So with Center's study that was published in 2015, half of our population treat the burn patient by washing the burnt area with cold water, whereas in Center's, 3/4 of their population would dress the burnt area. And only one of our participants chose the patient education as one of the factors that influenced the healing process. And in Pereira's study, almost all of our population used analgesia as their burn regime, which corresponds with Pereira's, as his paper highlighted the importance of analgesia, especially in geriatric patients. And only 2 of our respondents focused on the importance of fluid resuscitation, whereas in Pereira, they emphasized more on it. In Coates' study that was published in 2005, most of our primary care-based physicians, they refer their patients, while in their study, they treat them. And our study and Coates showed similar results in regards to the utilization of the rule of nines, as the majority of both populations use it. In Lamb's study that was published in 2008, only a minority of their population used the rule of nines. Both studies found that half of the participants were based in tertiary care centers. And the strength of our study is that, to the best of our knowledge, this is the first Saudi-based study examining this topic, and we showed very significant results, and it was a prospective study. One of the limitations is that we had a small sample size, but since it's a pilot study, that warrants potential for future studies. And also, one of our limitations is the dependence of the results on the participants' willingness to cooperate. Our conclusion is that this study showed that significant number of physicians who do not follow the international guidelines published by World Health Organization, and most physicians do not feel comfortable attending to the burn patients. We recommend making mandatory courses for burn management for doctors that cover the principles of burn trauma, following the international protocols as we highlighted. And we also recommend making the burn management a yearly examined topic, along with emphasizing the importance of patient education. We thank Dr. Mohammed Anwar Khan, Jawahir al-Tamimi, Sumaya bin Laden, Mohammed Khalifa, and King Saud bin Abdulaziz University Research Unit for their extremely valuable guidance. And thank you so much for listening.
Thank you so much, Dr. Hadil. This is a very well presented study. Any questions for Dr. Hadil? Yeah, please, Dr.
Thank you.
The point is that we do studies, and studies are put in drawers, and they not come to application. For this study to become useful, it has to be a nationwide study in Kingdom of Saudi Arabia to start with, and then similar studies should be carried in the Gulf area,
Yes.
where facilities and financial support and things like that are similar.
Yeah.
And from that, we can draw conclusion. Who are supposed to treat major burns? Because unfortunately, in most of our area, burns are not well considered when they are first seen, and still dermatologists will start attending burns if they are not extensive in percentage of area, but in depth of area. And then
Yes.
when things become complicated, they refer them to us.
Yeah.
Nationwide, we are speaking this morning about having protocols. It's too late for the Middle East not to have protocols about management. Who should treat? What should you treat? How should you treat? And things like that.
Yes.
I learned a lot from the nurses who were working in the burn unit, where I got my training
Yeah.
in the first place. And unfortunately, nowadays, most of the young doctors, they escaped the burn unit. They don't like it. It's not rewarding. And even the administration is not giving enough rewards to the nurses who are working
Yes.
in burn units. They should be considered as front lines, and they should be rewarded as those who are working in emergency, not in emergency, but in intensive care.
Yes.
Because those are patients who are staying days after day. Complications can occur at any time and so forth. So what I am suggesting, it's a very good study, but it should be put in action. It should be put on action by having similar studies nationwide, Gulf area-wide, and then you can refer it to a multi-center studies may be carried in the Middle East, and we should draw conclusion, and the conclusion should be implemented. There are waves coming up every now and then, even in our country, in Egypt, and then the waves fade away after some time and nothing is accomplished. But it's a very good study. I congratulate you and whoever was supervising you in this
Dr.
study.
Muhammad Al-Qahtani is the
لا ما محمد
supervisor.
القحطاني شهادتي فيه مجروحة لأنه صديق عزيز. But this is actually a fact.
Yeah.
We are lacking this in our area.
Yes.
Thank you very much.
Thank you. Thank you so much. Now
Thank
it's
you.
the coffee break.
All right, we are at the end of session number 4. Thank you so much, Dr. Hatem. And I would just like to make an important announcement. All the faculties are invited for dinner, sponsored by GEM International. Please get together at lobby at 7:45 p.m. and the bus will leave at 8 o'clock. All right? I repeat, all the faculties are invited for dinner sponsored by GEM International. Please get together at lobby at 7:45 p.m. sharp, and the bus will leave at 8 p.m. Kindly proceed for coffee break. I shall see you soon. Thank you. I will just. Welcome back, lovely crowd. Now, may I please call upon the stage Ms. Dr. Ziad Al Harbi. Dr. Ziad, kindly address the crowd ahead.
So good afternoon, ladies and gentlemen. I would like to introduce my colleagues for this last session of today for the burns. And we would like to welcome our colleague, Dr. Saeed Al-Busaidi, Senior Consultant Plastic Surgeon in Khola Hospital in Muscat. Please, Dr. Saeed, the floor is yours, and go ahead with your presentation. Welcome, Dr. Saeed.
Thank you very much, Dr. Ziad, and I would like to thank the organizing committee for inviting us and for giving wonderful session for the experience from Oman. And I'm going to talk about our experience with MIG micrografts. They are a challenge at several aspects. And one of these aspects is the wound cover.
Dr. Saeed, your voice is not that much clear. Can you set the volume of the voice, please?
Is it better now?
Yeah, now it's volume a little bit of the voice, please, and go ahead with the presentation.
As you know, in this situation, there's a limited graft source, and people are available to deal with such a situation. Micrografts were introduced by Cicero. Basically, he was a general practitioner who had some interest in burns, and he developed the techniques of micrografts in 1958. Subsequently, this technique lost its popularity, and because of the development of the meshing technique, but subsequently in the 90s, it was revived again. For those people who are not familiar with the technique, it's simple. It is basically based on dividing the graft into small squares and spraying them with the glue, and the glue is and then the graft is transferred to a pre-folded gauze. Once the gauze is unfolded, it will get expanded. So it's a simple technique. So now it's almost 8 years since we started using it, and we are doing excision as early as possible, but it's not always possible to do it in the first 7 days in our setup. From 2014 until 2021, we did around 51 patients. All of them almost had to go a number of times for surgery. The age was 1 to 62 years. The mean age was 18 years. So it's a young, mostly young patients. There was a equal number of males and females. Most of these patients, of course, had flame burns, with few had scald burns. Total body surface area ranged from 18 to 90%. The mean surface area was 48. So as you see, most of these patients had extensive burns. Hospital stay ranged from 20 days to 170 days. 11 of these expired through the course of treatment. Initially, our initial experience with the MIG graft was not good, actually, because we had poor graft take, and we had to ask ourselves why there's a poor graft take, and we have to look for the reason. Theoretically, you will expect to have spaced micrographs that the take is much better, and if a small part is lost, then the rest of the graft will stay. But it didn't appear to be that way. In the literature, the same issue was reported in a number of articles, and all of these articles mentioned the early experience with poor graft take, and they have suggested a number of techniques that can enhance or improve the graft take. To summarize what is there in the literature, it's always a combination, integration with allograft, integration with culture resilience autograft, integration with mesh grafts, integration with dermal substitutes. So these were the things which was mentioned in the literature. For our setup, allograft is not available. CA also was not available. Mesh graft already are short of graft, and you are using the micrografts instead of that. Integration with dermal substitute, that was one of the solutions which was available to us to improve the graft take in this type of patients. Anyway, with experience, we realized that the problem is simple basically, and it's not that much complicated. It's basically the vascularity of the bed which determines the take of micrografts. So if the patient has full thickness burns and you have to go deep down to the subcutaneous tissue, as you know, the fat has got a poor vascularity, and that's the reason for the poor take of the micrografts. Other issues like infection and hypergranulation, these are basic issues that everybody knows about. The graft will take well if you have healthy granulation, if there's a layer of dermis after tangential excision, or you add a dermal substitute. That's what we gained with time. Back again to this patient who had 90% body surface area burns. He was managed by micrografts, and we didn't require to put any dermal substitute in his case, because after a tangential excision there was still a viable layer of dermis, and the micrografts were applied, and it was taken well. This child also had extensive burns, and for him, as it was full thickness, we managed him with combination of dermal substitute, and usually we're using a single stage dermal substitute and combined with the MIC micrografts. This is another patient who had also extensive burns, 65% burns, and managed with both combination of dermal substitute and MIC micrografts. And this is the way it looks after the full healing. This patient had also an extensive burns, 85% total surface area, and had to go to surgery several times. And at the end, there were some wounds were granulating, and once micrograft applied on them, the take was very good. This patient also, he was a child and initially come to us at 75% total surface area burns after tangential excision and application of the micrografts. It didn't take well, and that also the patient could not be taken to the theater for some time. By that time, there was a granulation formation, and also we noticed that some islands were remaining. Islands epithelialization started spreading, but of course it didn't cover the whole area, so we had to take him again for further grafting. Him after complete healing, and 3 years later, and 6 year post-burn. So in conclusion, MIC micrograft is not our first choice for extensive burns because of the issues that mentioned, and also because of the cobblestone appearance that would be seen in some situations. Graft take can be improved by combining it with dermal substitute. Thank you very much.
Thank you very much, Dr. Saeed. Well, I have a question regarding the micrografts or the anyway in the sort of MIC technique. Do you face some infection problems? And if you do so, how you treat them? Do you inflate, for example, antibiotics in a systemic way or a local antibiotics? Or what is your approach?
Yeah, I mean, the infection is quite common in burns patients, as you know. So if there is a wound infection, then one of the issues with the micrographs that sometimes the thick secretion accumulate underneath the gauze and the graft itself, and it will get elevated from the bed, and
Okay.
it will end up in graft loss. So what we do usually, we make incisions in this
Okay.
gauzes in order to replace the graft back again, and of course we treat the wound with topical antibiotics if there's systemic infection
Okay.
as the patient.
So rather than taking the whole material out, you make an incision selectively in the place.
Yes.
Yes. Well, thank you again very much, Dr. Saeed, for a very illustrated presentation. I would like to welcome our dear colleague, Dr. Karim Haridi, from the Sultanate of Oman in Khawla Hospital, consultant plastic, reconstructive, and burn surgeon with multiple fellowships beginning from general plastic and hand surgery in Tübingen in Germany, and general plastic and ear reconstructive fellowship in St. John's Hospital in Edinburgh. Welcome.
Or only here? Good afternoon, everybody. I know it's a little bit late at the end of the day, but I hope this presentation find you well. This presentation is about a report study from about cutaneous drain opener burn, which is the most common type of chemical burn we face in our burn center in Oman. Chemical burn injury are usually industrial, but most of the time in Oman we face it as home or domestic injuries, as drain opener is the most common cause of this type of burns. Drain opener are available in powder and liquid form, and it may be alkaline as sodium hydroxide or acid as sulfuric acid, which causes burn when it gets in contact with the skin. This is a study we published. It was with a lot of colleagues from medical school of Sultan Qaboos University, from the pharmacy department, and most of the people from plastic surgery department in Khawla. We published in March 2019. It's a retrospective study of drain opener chemical burn, which presented to Khawla Hospital, Muscat, Oman, between January 2013 and December 2017. Khawla Hospital, it's a tertiary care hospital located in Muscat. It's the capital of Oman. It's a central burn unit in the country. Chemical burn or chemical injuries seen as an outpatient in the clinic or casualty or as an inpatient in burns unit, all of these cases were included in the study. The analysis included demographic data, total body surface area, parts of the body involved, first aid given, need of intubation and ventilation, need for ischorotomy or fasciotomy, systemic poisoning, and need for surgery and outcome, including scar characteristics. Over the period of the study, we received 224 patients with chemical burn, which were identified as 126 of cases had injury by drain opener. Out of 224, 126 were by drain opener. Patients with drain opener burn were included in the analysis, and other burn were excluded. There were 101 male, which is 80% of the study, and 25 female. Age range between 1 year and 86 years. The main age was 29.6 years, and the children, we include between 1 and 12 years, it was 23, the mean was 23, around 18%. The majority of patients, 117, had 10% or less of the total body surface area affected. Burn distribution according to the involved body parts, it was head and neck was involved in 40 patients, trunk involved in 25 patients, upper limb involved in 74 patients, hand itself it was 22 patients, lower limb 47 patients, and perineum involved in 6 patients. Regarding the depths of burn, we have superficial dermal burns, which was reported in 47 patients, mixed superficial and deep in 37 patients, and it was deep or full thickness burn in 42 patients. So the percentage is the same, almost the same in all the types of burn. There is no systemic poisoning reported in any of the cases.